be rounding up uh, with our respiratory. Okay. Okay. So I think we stopped at COVID last time. So today we are going to be starting with the pulmonary vascular disease. I welcome everybody to the respiratory episode. My name is still Dr. Babawali, and we are going to continue by talking about pulmonary hypertension or called pulmonary. Yeah. So please, can we hear me? I need to be sure that we can hear me well. Can we hear me?
Yes, we
Okay.
can.
Okay. So what is pulmonary hypertension? Pulmonary hypertension is when the pulmonary arterial pressure is more than 20. That's all you need to remember. When the pulmonary arterial pressure is more than 20 at rest, that is pulmonary hypertension. We have to remember the classes, class 1 to 5. Class 1 is when the etiology of the hypertension is due to problems within the pulmonary arterial system. So, the commonest one is the idiopathic pulmonary hypertension, which is due to the BMPR2 mutation. I'm sure we remember this from our step 1. And you have a mutation that is causing a loss of function of this BMPR2, bone morphogenetic protein receptor 2. And the major function of that receptor is to inhibit vascular smooth muscle proliferation. So once you have a mutation of that receptor, you don't have any control, over vascular smooth muscle proliferation. So you have an abnormal proliferation of the vascular smooth muscle, which can occlude the lumen of the pulmonary arteries, leading to hypertension. So that's the commonest. But you can have pulmonary arterial hypertension coming from other things affecting the arteries, which is not idiopathic. Like people with connective tissue disease, you know, the Ehlers-Danlos, the scleroderma, people with portal hypertension. Because you remember that people with portal hypertension, they have, this abnormal shunting of blood bypassing the liver, entering the systemic circulation directly. And most of those blood entering that systemic circulation is rich in serotonin, which can proliferate the smooth muscle, causing pulmonary arterial hypertension. Don't forget that the component of the pulmonary vasculature that we are looking at in group 1 is the artery. So, scleroderma for the connective tissue, portal hypertension due to serotonin effect, schistosomiasis due to the hex, inflammatory response to the hex can affect, the pulmonary arterial system, and you can have abnormal proliferation. So, HIV. So it's believed that HIV can also cause pulmonary arterial hypertension because of the rigorous inflammatory response in people with HIV. So that can also cause pulmonary arterial hypertension and people with congenital heart disease. So don't forget that the idiopathic, the BMPR mutation, connective tissue, portal hypertension, schistosomiasis, HIV. Then for the type 2 or the group 2 are the ones that the pulmonary hypertension is coming from a problem with the left side of the heart. So they have like an heart issue. Either they have aortic stenosis, mitral stenosis, mitral regurgitation, mitral, whatever pathology affecting the valves, that is causing blood to pull up, in probably the left ventricle, the left atrium, and from there they can move backwards to the pulmonary veins. When the pulmonary veins becomes congested, you have a backward pressure transferred to the pulmonary capillaries and the pulmonary artery. So, which can be a cause of pulmonary hypertension. The group 3 is not the heart, but problems with the lungs. So, or the person is just breathing at high altitude causing hypoxia. Anything that can cause hypoxia would be a cause of the group 3 pulmonary hypertension. If the person is breathing at high altitude, there will be hypoxia. If the person has interstitial lung disease, there's hypoxia. If the person has asthma, COPD, hypoxia. And remember the pulmonary vasculature response to hypoxia, there's vasoconstriction. And when there's vasoconstriction, there's hypertension. That's group 3, the lungs, or hypoxia from henicus. Group 4 is chronic thromboembolic disease. So anybody that has any cause of thromboembolism that is recurrent, either the person has a malignancy that is allowing the person to clot constantly, or anything, factor 5 leading, anything that is making the person throw clot constantly, can reduce the surface area of the pulmonary vasculature, leading to pulmonary hypertension. Group 5 is systemic. So it could be from anything, from vasculature, maybe people with sickle cell disease, metabolic cause, people with diabetes, sarcoidosis, anything. Group 5. So there's something called cor pulmonale. So cor pulmonale just basically means there's a problem with the pulmonary vasculature, which is causing a remodeling of the right ventricle. That is what you need to make diagnosis of cor pulmonale. There must be a problem with the respiratory system, because if you look at the name cor pulmonale, there's a pulmonary component to the nomenclature. So there has to be a problem with the lungs. If there's right ventricular problem but there's no problem with the lungs, you cannot call that cor pulmonale. So if, for example, there is hypoxic vasoconstriction, pulmonary hypertension, and you have right ventricular hypertrophy, that is a form of cor pulmonale. And at the end of the day, when you have right ventricular hypertrophy, the adaptation might not be sufficient to take care of the problem, and the heart will start failing, and the person can proceed to develop right ventricular failure, which is going to, lead to the person having elevated JVP, blood going back to the liver, hepatic congestion going back to the legs, causing edema. Features of right-sided heart failure. So it might not get to the right-sided heart failure because that's what most people wait for, but something as little as the remodeling, which is the right ventricular hypertrophy, is sufficient for you to make diagnosis of cor pulmonale, which is usually a problem with the group 3, group 3, hypoxic vasoconstriction, because that's the one that's related to the lungs. Now, moving on to the history. Somebody with pulmonary hypertension, how do you expect them to present? You don't need to worry yourself. Just have it at the back of your mind that they will be tired, because their pulmonary vasculature are not going to be doing what they are supposed to do. They are congested. There's hypertension in that area. You are not going to be having adequate oxygenation. So the person is going to be feeling dyspneic. They'll get exerted. Minimal work. They are tired. They are fatigued. And when the remodeling starts happening, right ventricular hypertrophy, they start developing chest pain, from the angina, because the oxygen demand of a ticking heart is going to be more than the normal heart. So they're going to have chest pain and later right-sided congestive heart failure, which is going to lead to edema, abdominal distension, and the JVP. So sorry about that. So how is the history going to look like? So the history is going to look like any of the groups, depending on the cause. The person might have liver disease, portal hypertension, causing the group 1. The person might have heart failure for mitral stenosis. The person might have emphysema or COPD for the group 3. The person might have malignancy, that's when the group 4, or for the group 5, maybe sickle cell, sarcoidosis, diabetes, depending on the cause. So the history can present anyhow, depending on the cause of the pulmonary hypertension. So if you do your examination, what do you expect? Your loud P2, because this is pulmonary hypertension. The P2 sound, the P2 component of your second heart sound is going to be loud, and there's going to be a split, because it's going to take a while before your right ventricle can empty completely into the pulmonary vasculature to allow your pulmonary valve to close. So it's going to take a long time for your pulmonary valve to close, which is going to cause a splitting, the delayed closure of, the pulmonary valve, causing a split in the S2. So the S2, the P2 component is going to be loud, and there's going to be a split. And of course, there's going to be a flow murmur because of the resistance in the right ventricular emptying into the pulmonary system. And of course, there's going to be a fourth heart sound. You know that. Anybody wants to remind us why there's going to be a fourth heart sound from our cardiology knowledge? Anybody? Just to know that we are following me. Anybody?
The ticking right ventricle.
Yeah. So the ticking right ventricle, but you have to be precise. The ticking is due to what? A form of a pressure overload. Do you get it? It's not volume. So
Yes.
it's working against a pressure and increased afterload. So the modification is going to be like a concentric hypertrophy. So once you see that, you expect a S4 sound. Any cause of hypertension, systemic hypertension, pulmonary hypertension, the concentric remodeling is going to lead to, reduced compliance. So stiffness in that ventricle causing the S4 sound. But if it's a volume overload problem now, you expect S3. And of course, the right ventricular hypertrophy is going to lead to the parasternal heaving. So, but I must mention that it is not only pulmonary hypertension that you expect a loud S2. Somebody with pulmonary embolism can also have a loud S2, but with that, you are rest assured that, okay, there must be something wrong with the pulmonary component. Especially if they tell you that probably it's the P2, okay, there's like maybe some occlusion or some resistance in the pulmonary side that is making that sound very, very loud. So I know these are stuff we can figure out in the exam. Don't forget the symptomatology. They are tired, fatigue, distal exertion, syncope, lethargy, the chest pain, and the likes. So what are the other things that can cause embolic disease? Just key fat. People that just delivered, they can have amniotic fluid embolism. We know how they are going to present. We have done the O&G. The fat embolism. Don't forget the fat embolism triad. The petechial rash, the dyspnea, the fracture, history of the fracture, and the confusion from the neurological aspect. The cardiac surgery, they can also have hair embolism following cardiac surgery, and the vascular procedure, cholesterol embolism. For this cholesterol embolism, always watch out for your mottled skin. So the mottled rather, not mottled skin. They will tell you that the skin is kind of mottled. Think of maybe levado reticularis and the likes. Have cholesterol embolism at the back of your mind. How do you investigate somebody with pulmonary hypertension? What is the first thing you want to do? I'm not saying the best, but the first initial test. Don't forget, it is your echo. You are going to do your echo. And what are you looking out for? The pressure. You want to, check for that pressure, to make diagnosis of pulmonary hypertension. The pulmonary arterial pressure is going to be elevated. It's going to be more than 20. And of course, you want to see the functioning of the right ventricle if it has started undergoing the remodeling for the corpus pulmonale. And you expect what? Your right ventricular hypertrophy, and sometimes you notice hypokinesis. It will not be contracting adequately. So when it's becoming flabby hypokinesis, you know that, oh, this guy is already failing totally. You can have some valvular abnormalities. Like, anybody wants to tell us what valvular abnormality do you expect in someone that has a flabby right ventricle? What do you expect?
Regurgitation.
Yeah,
Speed
tricuspid
regurgitation.
regurgitation. It's as simple as that. Then you can do your chest X-ray. What are you looking out for? The question can portray this. They will tell you, that the person presents with dyspnea, fatigue, blah blah blah, and probably the person has a history of COPD, and they did the chest X-ray. They were seeing enlargement of your central pulmonary artery with a tapering of the distal vessel. Just know that blood is not getting to that distal one. The blood is kind of confined within the high pressure zone of the central pulmonary artery, and it's not making it get to the distal part. So there's going to be tapering at the distal part, and there's going to be enlargement at the central part. So that is also in keeping with what you expect for pulmonary hypertension. Don't forget that, because you can see this in the question: enlargement of your central pulmonary artery and tapering of the distal vessel. Very classic for pulmonary hypertension. If you do your ECG, you are going to see evidence of your corpus pulmonale remodeling, right ventricular hypertrophy. And how do you make diagnosis of right ventricular hypertrophy? Your R wave is going to be tall in V1, more than 7 millimeter. What's your diagnostic test of choice? What do you want to go for? The best. If they tell you the most accurate test or the best, it is your right arterial catheterization. Very, very important stuff. The best initial, your echo. All these ECG, X-ray, they are just adjunct. Your best initial is your echo. Your most accurate test to make your diagnosis is your right heart catheterization. So just put in your catheter and enter your pulmonary artery and read the pressure there. It's going to be more than 20. And I have something here which is your pulmonary capillary wedge pressure that can help you separate between the causes. So if you see that the pulmonary capillary wedge pressure is more than 15, you are thinking of a left heart cause of the pulmonary hypertension, because The pulmonary capillary wedge pressure gives an estimate of your left atrial pressure. It gives an estimate of your left atrial pressure. So if the left atrial pressure is high, your pulmonary capillary wedge pressure is going to be high. And you can say that, oh, it's possible that this pulmonary hypertension is coming from the left side. But if it's less than that, you can be thinking of any other thing, maybe the lungs, maybe your recurrent thromboembolism or idiopathic. So that's that about your pulmonary capillary wedge pressure. How do you treat? Just take care of the underlying problem. COPD, give oxygen, give your corticosteroids. Asthma, the same thing. Heart failure, give your digoxin, right? Give your diuretics, give oxygen. Then you might need to anticoagulate people with the left heart cause of the pulmonary hypertension, because, for example, someone with mitral stenosis now, there's a chance that you have stasis of blood within the left atrium, which can lead to formation of clot due to the stasis within that area, and atrial fibrillation can also occur in that area, which can allow for embolization. So I know that we know this from our cardio; it's not something new, but there are some treatment that are specific to some groups that you must not forget, and that is your group 1. Most of the time, the pathology is going to come from either group 1 or group 2 or group 3. So once you look at the question stem and you are picking that, okay, the cause is likely from the group 1, the primary pulmonary arterial hypertension, think about 3 drugs. Your prostanoids. You want to vasodilate that artery. That is what you want to do, because this is an arterial problem. Vasodilate that artery. Your prostanoids. So those are your PGI2. Your beta prost, your epoprostenol, your hyloprost. The commonest one you see is your epoprostenol. You can also see your hyloprost. You don't need to cram them. By the time you see them in the options, you remember. So they are not something that is fallacy. The endothelin receptor antagonist, because endothelin is a vasoconstrictor. So why not block the receptor for endothelin? And that's why you give your bosetan, right? Anything setan, ambrisetan, macitetan, bosetan, they are all endothelin receptor antagonists. And of course, your phosphodiesterase inhibitors, because once you inhibit phosphodiesterase, you cannot break down CMP. CMP accumulates, allow for vasodilation. So your sildenafil, your tadalafil, your vardenafil helps to improve the hemodynamics and exercise tolerance in them. Don't forget, and remember the class you are giving these 3. Your class 1, people with the arterial 1, the arterial cause of the pulmonary hypertension. What other class do you not want to forget? People with the class 4, you don't want to forget that. Okay, before I go, there's something you call the vasoreactivity test for the class 1. So sometimes they can use calcium channel blockers. That used to be the mainstay of treatment before you have introduction of all these 3 drugs. And what they do is that they try to do your catheterization, and they will administer intravenous inhaled nitric oxide, and they are going to watch for the reduction in the pressure. So if it drops by more than 10, let's say it's 25 and it drops to 14 or 13, okay, there's a reduction of more than 10. This agent is likely going to respond to calcium channel blocker, so you can give it. So that's just for your information. Have these 3 at the back of your mind, not the calcium channel blockers first, please. Group 4, thromboembolic disease. So people with thromboembolic disease, these guys are going to have a reduced surface area of their pulmonary arterial vasculature, and what you must do for all of them is surgical thromboendarterectomy, the big word for just go in and remove the clot. That's what it means. But you might have some situation in which you cannot operate that patient, so you might need to do a less invasive approach, and that's when the ballooning comes in. So you do your balloon pulmonary angioplasty, or you can give them some new drugs which you call the riociguat. So this riociguat is just more like a CGMP analog. It can also help to relax the vessel and reduce the clot formation. So, but the definitive mainstay of treatment for the thromboembolic one, the group 4, is what? Surgical thromboendarterectomy. That is what you are going to be looking for in the question step. But if the person is not fit for surgery, do your balloon pulmonary angioplasty, and you can also administer your riociguat. Never forget that. Moving on to pulmonary embolism. This means, let me see if I have any question. I think I have 1 or 2. Let me see. So a 69-year-old man comes to the office due to uh, 2 days of increasing shortness of breath, cough, lower extremity edema. Okay, I'm trying to enlarge this thing, but I can't. And he drinks half of a bottle of vodka daily and 45 pack year smoking history. There's no past history of hypertension or ischemic heart disease. So this guy is a smoker. He has cough, shortness of breath, and lower extremity edema. So kind of the heart is already failing. The the patient has a sedentary lifestyle due to disability from a work injury at the age of 20, takes some medication, not seen a physician in 20 years. BP is 130/90, pulse is normal, oxygen saturation is 90. Cardiac examination shows faint heart sound. Jugular venous pressure is 11 centimeter of water. Lung auscultation shows decreased birth sound. The liver span is 18 and ascites present. There's a bilateral 3 plus lower extremity edema up to the knees. The chest X-ray shows enlarged central pulmonary arteries without evidence of vascular congestion. Which of the following is the most likely diagnosis?
Pulmonary.
Pulmonary. So this person is already having pulmonary hypertension, evidenced by the X-ray finding, enlarged central pulmonary arteries without evidence of vascular congestion. What are they telling us? What do you think this is telling us? Anybody?
Shows pulmonary oligemia, the pulmonary artery, that's kind of vasoconstriction, so not enough blood is passing through.
Yes, that is okay. Okay, but
That's the pruning. The
the,
pruning, they say, you see.
yes, yes, yes. But there's another thing again you can infer from this. There's a possibility to this absent vascular congestion. What do you expect if this person has a left side failure?
The PCWP will be elevated.
Yes, but will there be vascular congestion?
Yes,
Yes, there will be vascular. So they are trying to tell you that this is not from the left side. So, and
yes.
if it's not from the left side, you not have any vascular congestion, and it means that you can have core pulmonary as your diagnosis. Because if it's coming from the left side, it means that the problem is coming from the left side, transmitting it to the right side. You cannot call that core pulmonary because it's not primarily from the lungs. So they are trying to tell you that don't be thinking about heart problem. Oh, there's no vascular congestion. So that's very good. So the problem is actually maybe the person has COPD or something. We don't know. So, but the heart is okay. Okay. I think is it only one? Let me see. Okay, I have plenty. A 40-year-old man comes to the physician because of 2 episodes of loss of consciousness over the past week. He recovered immediately and was not confused following the episodes. During the past 5 months, she had increased rate of breath and palpitation. She has been unable to carry out her daily activities. We can see the tiredness, loss of consciousness, not able to carry out activities, shortness of breath, palpitations. She also reports some chest tightness that resolves with rest. Okay, more like angina, right? She also has no history of serious illness or takes no medication. See, she immigrated with her family from India 10 years ago. Blood pressure is normal, pulse is elevated, temperature is normal. Examination shows jugular venous distension and pitting edema below the knees. Bilateral crackles ahead at the lung bases. Cardiac examination shows accentuation and splitting of S2. There is an opening snap followed by a low pitch diastolic murmur in the fifth left intercostal space mid clavicular line. ECG shows atrial fibrillation and RAD, right axis deviation. Which of the following is the most likely underlying mechanism of this disease? Anybody?
Increased left arterial pressure.
Fantastic.
There's a left mitral, in the mitral valve stenosis.
Yeah,
So cause the accumulation and the atrial fibrillation. The
exactly.
patient is, and
So
the transferred pressure on the right side of the heart.
exactly. So what other drug do you think you want to add to this patient?
You give an
You want to
anticoagulant.
give an anticoagulant. The person is having atrial fibrillation, there's mitral stenosis with the pulmonary hypertension.
Yes,
So
yes.
give your anticoagulant. Very, very important. Give your diuretics, give your if you want to assist with, okay, this will not be like a contraction problem, but give your diuretics, give your anticoagulant, then take care of the cause of the mitral stenosis. If there's going to need replacement of something, do that. Okay, that's very easy. So we cannot call this pulmonale, right, Dr. Antonia? Can we call this pulmonale?
No, because it's not, the problem is from the left side.
Exactly. Good. A 42-year-old woman comes to the physician because of 1 year history of progressive fatigue, shoulder or breast on exertion. 45 years ago, she emigrated from Eastern Europe. She has smoked 1 pound of cigarette daily for 20 years. She has an history of methamphetamine and cocaine use, but quit 5 years ago. Vitals are okay. There's elevated JVP. The lungs are clear to oxygenation. What does that rule out? Anybody? The lungs are clear.
Pulmonary edema.
So that rules out a left side cause, pulmonary edema. There is a normal S1 and loud S2. An impulse can be felt with the finger left of the sternum. What is that? Anybody? What is that?
Pulmonary heave.
Yeah, your parasternal heave, which is suggestive of what?
Right ventricular
Right
hypertrophy.
ventricular hypertrophy. You can see the way you are going to be looking at the question. You even know. That's one thing I like to do. Although different people have different school of thought, but my own approach is for you to understand the question, have a diagnosis at hand, because it's going to help you. If you don't have a diagnosis at hand, there's a tendency that you might miss this question. Another person might think this is heart failure. Fine, this might be the person having heart failure, left-sided problem, and the person might go for decreased left ventricular contractility. That would be wrong, because the problem is not within the left ventricle. The problem is above the left ventricle, which is at the mitral valve. So it's not going to be able to get into the left ventricle, right? They will just think, it's affecting the left side now. There's congestion at the lung basis. Let me go to heart failure, decreased left ventricular contractility. They miss it. But because you have your diagnosis, your working diagnosis is what? Mitral stenosis causing your group 2 or your class 2 cause of pulmonary hypertension. So you know what you are looking out for, and you pick your answer confidently and you move. So that is that. Have your diagnosis at hand and look for the corresponding option that will explain whatever you are saying. So sorry about that deviation. An impulse can be felt within the finger. That's the parasternal heave. The abdomen is soft, non-tender to palpation. The fingertips are enlarged, okay, and the nails are curved. There is pitting edema around the ankles bilaterally. X-ray of the chest shows pronounced central pulmonary arteries and a prominent right heart border. Which of the following is most likely going to confirm this diagnosis? So this patient is having progressive fatigue, shortness of breath. He had been smoking for 20 years, right? He takes drug, the cocaine, he met, but quit 5 years ago. I must mention that the meth and the cocaine can also cause the class 1. It's also part of the causes of the class 1 because they can cause spasm and constriction of the vessels. But this guy quit 5 years ago. And now he's now having elevated JVP. The lungs are clear. There is a loud and split S2. An impulse. So it means that there's a problem with the right side now, not affecting the left side. An impulse can be felt with the fingers left of the sternum. So there's parasternal heave. So there's already right-sided right ventricular hypertrophy, pulmonale. The fingertips are enlarged and the nails are curved, so that's like finger clubbing, right? So this means that this is a chronic problem. There's pitting edema around the ankles bilaterally, further talking about the right ventricular failure, and the X-ray shows pronounced central pulmonary arteries and a prominent right heart border. In some of that is smoking. What do you think? Anybody?
Not pulmonary. The right heart catheterization.
Sorry about that. Because what is like going to confirm the diagnosis. So it's going to be, right side catheterization. That's very correct. Okay. Yeah. So let us move on. So pulmonary embolism. So this is just a condition in which you have occlusion of the pulmonary vasculature by blood clots. 90% of them originate from the leg veins. You have to know that. Majority of the time, the DVTs, they the major cause of PE is what? A dislodged DVT, right? And most of the DVTs occurs in the deep veins in the lower part of the leg. But the ones that actually dislodge, that causes the PE, are the ones that are proximal. So the ones that you see in the femoral and the iliac veins. Very important you remember that. And it can lead to infarction, right heart failure and hypoxemia. So what are the causes of the venous thrombosis? We remember a vital triad: venostasis, endothelial injury, hypercoagulability. Don't forget that. What are the things that can cause stasis? All these things: immobility, pregnancy, congestive heart failure, obesity. All those things we have treated before. Endothelial injury, just think of trauma, fracture, you know, previous DVT can irritate the endothelium. Surgery, causes of hypercoagulability, we know this from people that are smoking, people that have malignancy, postpartum because of the elevated fibrinogen, in pregnancy and postpartum state. OCP use, you know, we have to be very careful with that. You have to have high index of suspicion. Someone that is having OCP and suddenly have P, that's that, or suddenly have chest pain, that's likely to be a P from a DVT. So OCPs are very much associated with hypercoagulability. They test this a lot. We have to know it. Protein C deficiency. So not something I have to waste my time on. Delete this Wells criteria because we are not going to be working with this. We are going to be working with the modified Wells criteria. P is very high huge. You have to know it. It looks simple, but people might make mistakes. Please don't make the mistake because it is cheap marks. If you see P in your exam and you are banging it, it is a problem because it's very easy to get once you know the rule. So don't underrate P that should be just P. Always make sure you calm down once you get a question with pulmonary embolism. How is the patient going to present? Everything is just sudden onset. Sudden onset difficulty in breathing. Sudden onset chest pain that is pleuritic. Tachypnea, tachycardia. Sometimes hemoptysis because you said they can cause pulmonary infarction. So once you see sudden onset difficulty in breathing, sudden onset chest pain, rule out P. They might be generous enough to tell you that the person has a history of immobility. Traveled from Nigeria to Australia. Person was bedbound in the ICU. Recently had a surgery. P. When you examine, what do you see? A loud P2, just like in pulmonary hypertension. And there is going to be prominent jugular hair wave when you plot your jugular venous pulsation graph. The hair wave is going to be prominent. So this is telling you that the right atrium is finding it very difficult to contract. It's contracting against the high pressure. That's why the hair wave is going to be very prominent. Very, very prominent hair wave with loud P2. An individual can present with massive pulmonary embolism that is causing what we call a saddle embolus. So, occluding the bifurcation of the central pulmonary vessel. So, an embolus at that point is very massive, and in addition to all this sudden onset chest pain, difficulty in breathing, you are going to have hypotension. And this is going to be the form of what type of shock? Anybody?
Obstructive
Shock. And there's going to be elevated JVP because you are going to have blood pulling up the right ventricle, the right atrium to the jugular veins. And because of the sudden distension of the right ventricle, there's going to be like a stretch on the bundle branches within the right ventricle, causing your RBB. I'm sure you will remember the ECG features of the RBB. Don't forget all those things. Very, very important. So once you see evidence of right bundle branch block, elevated JVP, hypotension, that is suggestive of a massive pulmonary embolism. Hypotension, elevated JVP, and a right bundle branch block. Massive pulmonary embolism. And in this kind of person, this is not the person you are going to be anticoagulating. You thrombolize immediately. So you have a high index of suspicion for pulmonary embolism. What's the next thing you want to do? You calculate your modified way. That is what you want to do. You pick up your pen and your paper and start calculating. Very, very important. You see, once you miss out this, you have failed it. I'm telling you. Calculate your well score, you have failed that question. Unless you get it by luck. So, always remember, once you are suspecting PE, what you want to do is calculation of your modified well score. I tell it I say to myself every time, Babs, calculate your modified well score. Very, very important. Don't fall into the trap. Calculate it first. And what are the parameters you are looking out for? That is the headmaster pit is deep. If you can remember this, is good. But what I just say to myself is just ask yourself, is this patient having malignancy or hemoptysis? Is the patient having malignancy or hemoptysis? If one of them is there, you give them 1-1. Hemoptysis 1, malignancy 1. Then, can you picture anything that relates to DVT? A calf swelling, tenderness, warm, pain in the calf. Those are suggestive of a DVT. Does this person have something that looks like a PE? Sudden chest pain, sudden difficulty in breathing. That is classic for PE. So you give them 3 if you can demonstrate that from a question. The person is having sudden onset difficulty in breathing, sudden onset chest pain. It's what you expect in a PE. So you have your 3 somewhere. You look at the history. They are saying that the leg is swollen, is tender, is erythematous. Classic for DVT. You give another 3. Then you now focus on your PIT, your PIT. Is there a previous history for your P? Previous history of DVT or PE, you give your 1.5. Your high, anything that suggests immobilization. The person had surgery in the last 1 month. The person was immobile for any cause in the last 3 days, 1.5. Then your tachycardia, your T, is a heart rate more than 100. You give your last 1.5. So the headmaster pit is deep. Your headmaster H, your what? Your hemoptysis, your hem for your malignancy, your P for your previous history of DVT or PE, your high for your immobilization, your T for your tachycardia. Then you focus on your D and your P. Is this person having something that suggests of DVT? Is this person having something that suggests of a PE? You give your 3. Your PIT 1.5 each, and your HM 1 each. You calculate it. So we are going to be having 2 probability assessment score, the traditional and the simplified. Most of the time, what you are going to be using in the exam is going to be the simplified, but you have to know the 2. Now let's talk about the simplified first. Once your result is more than 4, or once your result is 5 above, so let me say it again. Once your result is more than 4, or once your result is 5 above, PE is likely. So in that kind of person, the next thing you want to do is to do your contrast enhanced CT scan. If your calculation is 4 and below, PE is not likely. So what you want to do is to do your D-dimer test. That is for your simplified. So most of the time, that's what the exam will require you, to do. But sometimes they might be wicked and they want to put some traps. If you calculate and you are getting 7 and above, please, I said 7 and above, your traditional has to come into play. So what you are going to, because with 7 and above, your index of suspicion is very, very high. You immediately anticoagulate that patient. Please, provided the person is not having features of massive, we already said it that once it is massive, thrombolize. Don't be waiting for just thrombolize. JVP is raised, hypotension is there, RBB is there, thrombolize. But if you don't have that stuff, just normal presentation, difficulty in breathing, this and blah blah, you calculate, you are getting 7, give you empiric anticoagulation. But if it is 5 or 6, you know that 5 and 6, they are greater than 4, but they are not up to 7. You can now do your CT, but you don't give drug. You don't give your empiric anticoagulation. Just do your CT. So that is what I want to say in that aspect. If you are still doing your investigation and 4 hours don't pass, that is, you have elapsed 4 hours in the course of doing your investigation and you have not started the person on any drug, commence your anticoagulant. So let us look at the algorithm. If you calculate your modified well score and you are getting value of 4 and less, your best initial test is to do your D-dimer. Your best initial test is to do your D-dimer. Your best initial test is to do your D-dimer. And what? You rule out your pulmonary embolism. The D-dimer test has a very high negative predictive value. If you get your D-dimer test and it's negative, so there's a high chance that truly the person doesn't have it. That's what it means. It is not specific because there's so many things that can cause the DMR to change. Pregnancy, trauma, blah blah. Even if the person doesn't have the MPE. So that's why it's not specific, but it's very sensitive. So if you do your D-dimer and you are getting a value of 500 or more, you want to progress to do your CT scan. If the value is less than 500, stop. It's not likely to be P. Just think elsewhere. Once your D-dimer value is less than 500, think elsewhere. If it's more than 500 or 500 exactly, continue with your CT scan with contrast. Now, there might be some situations in which you cannot do CT with contrast. So that's why you have to calm down in that exam and make sure you are not missing any vital point. Does this person have a renal problem? Is this person pregnant? In that kind of person, you are not going to be picking CT. Contrast, do your VQ scan. You can see the reason why I'm saying that we have to analyze the question well before we pick any option we are going to be picking. So, if your modified well score is 5 and above, that is more than 4, you know your best initial test is what? Your CT scan. If the person is pregnant or the person is having failure of the kidneys, you cannot do your CT, so you do your VQ scan immediately. So, that is that. If you do arterial blood gas, what are you going to be seeing? Respiratory alkalosis, of course. This individual is going to be hyperventilating. So they can give you an arrow question, they will describe the PE, and they will tell you what are the changes you expect. You already know this is step 1 stuff. So there's going to be hypoxemia. Because of the hyperventilation, to get in more here, you are going to be taking out more CO2. So CO2 is going to drop. Respiratory alkalosis. Chest X-ray. So ideally, an individual with pulmonary embolism is going to have a normal chest X-ray. Don't fall for the trap. They can tell you that they did the chest X-ray, they did not see anything. That does not rule out PE. Do not fall for the trap. But in some small percentage of people, you can see some additional signs. But I know that it's this additional sign that some of us will now put into our head. I'll be saying, maybe there's no Hampton Hump, there's no West Palmer sign. It can't be PE, please. We have said it. Majority of the time, the PE is going to be what? It's going to be normal. But in some situations, you can have atelectasis. Why? Because when there is PE, you have reduced blood flow to the lungs. They cannot produce what they normally produce, which is what? Surfactant. When there is no surfactant, what is going to happen? Anybody wants to remind us, once surfactant is not available, what is going to happen to the alveoli?
Increase surface tension and collapse.
Yeah, so there's going to be increased surface tension, inward elastic recoil, collapse of the lung. Very easy. There can be pleural effusion because it can trigger some exudative inflammatory process, and you have exudative pleural effusion. Then, of course, you are going to be seeing the Hampton Hump, which is more like a wedge-shaped infarct, because of course you are cutting off blood supply to the lungs. There's going to be infarct, and West stomach sign due to the focal oligemia because you cannot deliver blood to the pulmonary vessels distal to the side of occlusion. So there's going to be West stomach sign. If you do your ECG, what do you see? Sinus tachycardia. Most of the time, you see your P wave, your QRS complex, your T wave, sinus. But by the time you calculate your distance between your RR interval, there's going to be tachycardia. Very easy. Sinus tachycardia. And in some few, proportion, you are going to see the Magen White sign, which is a X1, Q3. This one is just medical school people that go for quiz. Nobody's going to be asking you S1, Q3. Just keep it simple and know the basic simple stuff, right? Because if you have like 20 PE patients and you are feeling that you have stuff and you are talking about, is there S1, SQ? It's possible that you might not even see any S1, Q3, T3 in any of your PE patients because it's rare. So it's good to know it, but don't put that first in your mind. So your S1, which is more like S wave in lead 1, your Q3, which is Q wave in lead 3, and your inverted T wave in your lead 3. You can see it in PE. It's classic for PE, but it's rare. You can do your lower extremity venous ultrasound to rule out your DVT. How do you treat? The first thing you want to do, although the treatment is anticoagulation, fine, but the first thing you also want to do is to make sure that this person doesn't have a contraindication to anticoagulation. That is another place you have to calm down and you don't have to rush. Okay, I want to give this person anticoagulant. Does the patient has any contraindication to anticoagulation? Anticoagulation. What do I mean? I mean the person having aortic dissection, having GI bleeding, having suffered a stroke, having any cause of coagulopathy. You are not going to be coagulating. You are not going to be adding your anticoagulant to that kind of person. You want to do something else, and that is inserting your filter. But before we go there, let us go to the normal situation. This person doesn't have any contraindication to anticoagulation, and you calculate your clinical suspicion for PE. If it's 7, what do you do? Anybody? You calculate your clinical suspicion from your modified West score. You get 7. What do you do?
Immediate thrombolysis.
No. I'm not
You
saying
do
massive.
CT.
No.
7 and above.
So wait.
Anticoagulation.
Let me come again. So you calculate your West score, your modified West score, and you got a value of 7. So what do you do?
You start immediately.
You start your empiric anticoagulation. If the person has right bundle black block, elevated JVP, hypotension, so that is suggestive of a massive PE, then you thrombolize. Please,
Okay.
is it that I'm too fast? Please, am I too fast? Maybe I should slow down.
No,
I'm
you're
not
good.
fast. Okay. So, if you calculate your score 7, because in that situation your clinical suspicion is very high, 7 above, immediate empiric anticoagulation. But if you are getting 5 and 6 is still elevated, but it's not very, very high. So what you want to do, because that one is still more than 4, so the next thing you want to do is your CT, contrast CT. Provided the person doesn't have any contraindication to CT, which you might want to go for your VQ scan. But if the person is having 4, 3, 2, 1, what do you do?
You do D-dimer.
You do your D-dimer. You do your D-dimer. If the person is having 4 and below, do your D-dimer. If the person is having 5 and beyond, you do your CT. But if it's 7, empiric. So that's how you evaluate, and whatever you find, you treat accordingly. If the person has, question, I'm listening.
Yeah. So if the person has a massive one with hypertension and raised JVP and right bundle black, you do thrombolysis. So it's kind of different from empirical anticoagulant.
Yeah, it's different from you know that in thrombolysis you are not anticoagulating, you are breaking it.
You're breaking it, yeah.
You are
Okay.
breaking it. So your anticoagulation is just to prevent further clot from forming to get into the lungs. So that's the major reason why you are kind of anticoagulating. So but once it's massive and there's obstructive shock, break it. You have to break it. So if the person has a contraindication to anticoagulation, then you want to consider your IVC filter. That is after you have done your diagnostic evaluation and you see that, okay, this person actually needs anticoagulation, but I cannot give. So what are you going to do? IVC filter. But if you have seen that, okay, this person has contraindication to anticoagulation, and you did your evaluation, you cannot find any PE, leave the person alone. So for your acute treatment, you want to anticoagulate, what do you give? You can give a lot of, almost all the heparin, unfractionated, low molecular weight. From the Pyrenos, your Doxal, your direct observed anticoagulation, any one of them. But just keep your mind open and watch out for any of the risk factors that might not allow you to give any one of them. For example, someone with kidney failure, you cannot give low molecular weight. You want to use another thing, maybe unfractionated. That's the way it works. So someone with renal failure, you cannot use unfractionated. You cannot use low molecular weight, so you have to use unfractionated or use apixaban. Very important stuff. Apixaban or your unfractionated for renal failure. So that's where they hide. Then if it's chronic setting, chronic that is even causing pulmonary hypertension, so you might need to give something that you can use for a long time, which is maybe your low molecular weight. You can use your direct oral anticoagulant, which are the preferred one, or your warfarin. But you cannot use warfarin, especially in people that are pregnant. Don't use warfarin. And people that have pregnancy too, you cannot use your direct observed anticoagulant because the teratology profile is not well established. So don't use it. So the one you want to go for pregnancy is still your low molecular weight. Your low molecular weight. But if the person is fine, there's no pregnancy, you have to use your direct observe anticoagulant, your apixaban, because in that one you don't need to observe, you don't need to be doing serial IPPT check and the likes. So you are rest assured that this patient is going to be fine. So for chronic, you can use low molecular weight, you can use direct observe, direct oral anticoagulant, or warfarin. So you cannot use unfractionated because of HIT. You cannot place somebody on anticoagulant on heparin, unfractionated heparin for a long time. You are not expecting HIT. So, but your low molecular weight has low risk for HIT. So use it. So particularly if the person is pregnant, don't forget that. You can use that. If the person is not pregnant, use your direct oral anticoagulant. You don't need to monitor. You are okay. So I've talked about IVC filter, especially when the person has contraindication to anticoagulation, or you have anticoagulated with the maximum dose and it's not still working. Put in your IVC filter. People with thrombolysis are people with the saddle embolism that I said. They're having features of hemodynamic instability. The blood pressure is falling. JVP is rising. Right bundle blood thrombolysis. Then you might need to place the person subsequently on DVT prophylaxis, right? So that you prevent future episodes from occurring. The most effective is to encourage ambulation. Don't fall for that trap. Don't fall for that trap and go and be picking drug. The most effective prophylaxis. Please, madam, start walking. Go to the corridor, to and fro. You'll be fine. Then you can tell the person to, place the person on subcutaneous heparin, or you can use your test talking. So the test talking is even the least effective. The most effective is encourage early ablation. Moving on to the solitary pulmonary nodules. Very simple. Once you see this in your exam, just shout hallelujah and look at it calmly. Don't rush into it. So you can see all these solitary pulmonary nodules. Incidentally, when you do chest X-ray, maybe you are trying to evaluate for pneumonia or tuberculosis, and you just do your chest X-ray and you just see the nodule. There's a nodule here. We have to evaluate. So once you see a nodule, okay, let me talk about the presentation. Sometimes, most of the time, they'll be asymptomatic. It's more like an incidental finding. But sometimes they can have some non-specific symptoms. They can be coughing, they can have difficulty in breathing, shortness of breath, blah, blah, blah. And the next thing you want to do is to assess for the risk of malignancy. That is what you want to do next. Assess for the risk of malignancy. What do? You have seen it, the chest X-ray. Okay, you tell the people in charge, please, do you have previous X-ray of this patient? Oh, yes, doctor, we have. Okay, can you let me see it? Then you look at it. You look at the date, the time where they did that X-ray, maybe like 2-3 years ago. You look at it, how has it progressed? The one you are seeing, which is the old one, is kind of smaller than the new one. You know that is increasing. So you have a high index for malignancy. What do you want to do next? Order your CT. If the previous one you are seeing is the same as the new one, that means that's a benign stable lesion. You do nothing. No further evaluation is required. But if you see that there's a progression in the size, the shape, whatever stuff, evaluate for malignancy by ordering for your CT scan. Because the only way you can evaluate for malignancy is by doing your CT scan. Once you know this, you have solved like 20% of the problem. The only way you can evaluate for malignancy is not to order another chest X-ray. Is to what? Order a CT scan. Good. Now, I've talked about so you can also ask for some history. Are you smoking? For lung cancer? Are you exposed to anything? Maybe the person works in a shipbuilding, aerospace, insulator, mechanic, risk factor for all those dusts, which can bring about some of those nodules and malignant transformation later. Ask for history. Have you traveled to Cambodia? Have you schooled in Philippines? Have you traveled to Yemen? Are you in Nigeria? Tuberculosis. People living in the southwestern United States, California, the Colorado, I don't know, you guys should help me. People that live in the US. So have those states at the back of your mind, because they can also be suggestive of the underlying pathology. So people that live in California, the Colorado, the Texas, those southwestern US states, they can have coccidioidomycosis. We are going to talk about all these things. People that live in the Ohio River Valley or Mississippi. So once you are saying Ohio or Mississippi, you are thinking of two things: either histoplasmosis and blastomycosis. They are very easy to identify. It's like plantain chips. Like once you get them, you will get it. I can assure you, you will get it. They are very easy. So the first thing you want to do is just to compare the previous X-ray, 2 to 3 years. Is it stable or is it progressive? If it's stable, do nothing. If it's progressive, order your non-contrast enhanced CT scan. If you are evaluating for PE, you do a what? Contrast enhanced CT scan. If you are evaluating for a nodule, because you want to see the parenchyma of the lungs, you don't need any contrast to be disturbing you. You order a non-contrast CT scan. Very important. They can put both of them in the option and you'll be confused. You want to see you want to delineate that parenchyma, so you do a non-contrast CT scan of the chest. Now, once you have seen that, okay, before I move to this table, let me just make mention of some things. Now, we have said that this nodule is kind of progressive or something. You order your, so if it's progressive, you can order your CT scan. If they tell you that, doctor, please, we don't have the previous X-ray of this patient, you also order your CT scan. So those conditions, the previous X-ray is not available, or you see that the nodule is a new one, or it has progressively increased in size, you order your chest CT. Now, if you do your chest CT and you see that you can see some popcorn calcification, meaning you are seeing fat plus like calcified tissue, like fat with calcium deposits. That's like popcorn calcification. It suggests of a benign lesion. You do nothing. You do nothing. Popcorn calcification, you do nothing. Now, once you get your CT scan, what are the things you want to look out for? So this is what the say do not calcify comes into play. Say do not calcify. Say do not calcify. So say the S is talking about the smoking. Are you a smoker? Are you a smoker? You want to have that. If the person is never a smoker, it falls under the low category. Low risk for malignancy. If the person is a smoker, it falls under intermediate and high. Okay. Your next is your H. What is the H? How old are you, sir? Your bracket, your working range is 45 to 60. Your working range is 45 to 60. So it means that if the person is between 45 to 60, you put the person in the intermediate category. That's the way to remember it. Your working range is your 45 to 60. The person is more than 60, the person is under high. The person is less than 45, the person is under low. Then the Y is how many years, have you, if you are still smoking, good. You put on the person under high category. But if the person said, okay, I've stopped smoking, how long have you stopped smoking? Your working category, your working range is 5 to 15 years. 5 to 15 years. So I stopped smoking 15 years ago. So that's significant. So you put the person under low. The person tell you, oh, I stopped smoking less than 5 years ago. That is high. The person said between 5 to 15, intermediate. Don't forget for the age, 40 to 45 to 60. For the cessation of smoking, 5 to 15. There's your Y. Then your D is the diameter of the nodule. How wide is this nodule? Your working range is 8 to 20. So it means that 8 to 20 will fall under intermediate. Please, I'm saying 8 to 20 millimeters. Very important stuff. Because they can give you 0.8 centimeter. So that's 8 millimeter. So 8 to 20 millimeter, intermediate. Less than 8, low category. More than 20, high category. Your C. So we have talked about the diameter, we have talked about the H, we have talked about smoking, we have talked about yes since stopping smoking. Then your N, I've talked about D. Your N is your nodule characteristics. How does this nodule look like? Is it smooth? The border, is it smooth? Yeah, low category. Is it scalloped? You are seeing some irregularities. Scalloped border, irregular border, intermediate. Are you seeing speculations or coronal radiata? Meaning you are seeing some spiky projections. Spiky projections. They will tell you even the question stem is speculated. They will help you put it under the high category. If it's scalloped, intermediate. If it's smooth, low. Then your last is your classification. Are you seeing any classification? Yes. What does it look like? Is it central, uniform, popcorn classification? That's low. No classification, high. Or the classification is irregular, high. So say do not classify. Say do not classify. S, smoking. A for the H. Y for the H of the patient. Yes, since stopping smoking. The D for diameter. The N for the nodular border. The C for the classification. So that is just my own uh, algorithm. I don't know. You can use something else if you find it, or you can say SAD New York City, New York City, SAD New York City, smoking H D for the SAD, then in New York City NYC, the nodal, the years classification. Anyone that works, just have the algorithm. The one that takes 4 is going to be the one you are going to follow. So if you have diameter of less than 8, age less than 45, never smoked, you know, stopped smoking. So since the person has never smoked, is still going to be taking this. The nodal calcitis is smooth, so that means you already have 5. And maybe the person now has irregular classification. That's like 5-1. So the person is having more of the low feature, so you go for low. So that's how you are going to be separating them. So the one that has 4, at least 4, is what you are going to be picking. Please, do you understand what I'm saying? When I'm talking to myself, please.
Yes.
Good. So now you have done your algorithm. What are you getting? Are you getting more of the high? You see, once you are getting the high, the next thing you want to go and do is to go and biopsy and remove whatever is there. Just reset that tumor. Do your surgical resection. Sorry, not biopsy. Do your surgical remove it totally, because it is high risk for malignancy. If what you are getting is low and intermediate, then the next thing you want to do next is to look at the size. So if what you are getting is low and intermediate category, okay, I'm not going to reset to. Let me calm down, because I might need to biopsy. So what is the size? What is the diameter of this nodule? So your working range is 4 to 8. But here you have to be careful, because once you get a value of, so don't let me say 4 to 8, I'm sorry, let me correct myself. Your working range here is 5 to 7. Because once you get 8, once the diameter is 8, like you have segregated into low and intermediate, and you have asked yourself, what is the diameter? And it is 8 above, you have to go and do your biopsy immediately. Don't even calculate anything. Just go and do your biopsy, or you do your PET scan. So if you get a value, so if you get a high risk surgical resection, if it's low or intermediate, you want to determine the size. How big is it? Is it more than 8 or equal to 8? You do your PET scan or you do your biopsy and evaluate whatever you find. So if you see that it's suspicious for malignancy, remove it. If it's not suspicious, do your serial CT scan monitoring, because 8 is a lot. 8 is not something you can just abandon. So you have to do your serial CT scan monitoring. Even if you have done your PET or your biopsy, you are not seeing anything that looks like malignancy. But if you do your PET and your biopsy and you are seeing malignancy, reset it. So that's for value of 8 and beyond. If what you are getting is between 5 to 7, then the next thing you are doing, you have calculated it. You fell in between intermediate and low. Then you look at the size. It's between 5 to 7. Then the next thing you are going to do your serial CT monitoring. Serial CT monitoring. But if what you are getting is 4 or less, then you want to now look at the other parameters aside the size that support malignancy. If you are not getting anything, you just stop. If you are getting something, you do your serial CT scan. I know that this algorithm is a little bit controversial, but what you majorly need to know is when you do surgical resection, when you do your PET and your biopsy, and when you do nothing. You say once you know those 3 conditions, you are okay. You'll be able to solve any question. I'll show us some questions to consolidate what we have learned. So let me see if I have some questions. I didn't even solve question on B. Do we have any question here? Oh. A 52-year-old obese man comes to the emergency department complaining of acute onset shortness of breath. He twisted his ankle 5 days ago and had limited mobility. Other medical problems include DM, hypertension, CKD, right knee osteoarthritis. His medications include insulin, amlodipine, and low dose aspirin. The blood pressure is okay. The pulse is elevated, which is in keeping, you know, and hemoglobin is 11.2. Platelet is okay. The estimated GFR is 20 mils per minute per 1.73 meter square. Ventilation perfusion scan shows a right upper lobe perfusion defect with good ventilation. Which of following is the best initial treatment for this patient? Anybody?
Use unfractionated heparin.
That's very good. Very, very good. You can see the way they evaluated this patient. Like, they've already done the ventilation perfusion scan because they cannot do CT because um this patient is having CKD. So there's no way they can do CT. So they did ventilation perfusion scan and they showed us the perfusion defect. So it means that there's something occluding blood flow, right? So the next thing is to treat this patient, anticoagulate this patient, right? And what do you, because the blood pressure is okay, so the patient doesn't need thrombolization. The thrombolysis, the blood pressure is okay, is hemodynamically stable. So you want to anticoagulate this patient. But because of the CKD, you cannot give your low molecular weight heparin, right? You cannot give your direct oral anticoagulant too. So the only one you can give out of the direct acting oral anticoagulant is what? Anybody remembers?
Apixaban.
You can give
Also,
apixaban. You can give apixaban, but you cannot give rivaroxaban. So you can give either apixaban or your what? Unfractionated heparin. So that's why D is correct. A 69-year-old man undergoes urgent laparotomy due to strangulated inguinal hernia, necessitating resection of 40 centimeters of small bowel. On the morning of the fourth post-op day, he falls while getting out of bed. Afterwards, the patient is responsive but confused. Speech is incoherent and he cannot remember what happened. The blood pressure is low, pulse is elevated, respiration is 28. Red sounds at the lung basis. Neck veins appear distended. The abdomen is soft and non-distended. The surgical site is unremarkable. ECG shows sinus tachycardia, a new bundle-branch block, and non-specific T-wave changes. Immediate resuscitation with wide open intravenous fluid is ineffective. Shortly after, the pupils begin to dilate, the pulse is 35, becomes unresponsive, and dies despite resuscitative efforts. Which of following is the most likely cause of this patient death? Anybody?
he had massive
Yeah.
pulmonary embolism.
Yeah. So, and what did they fail to identify? They failed to identify the what to do. What did they do instead? They started bombarding with fluid, and they did not quickly institute the thrombolysis, right? So that's
Yeah.
why the patient died. That is very correct. You can see the blood pressure is down, so that shows that person is already having obstructive shock or to thrombolize. So we can look for more questions and attack them. So let me see. I think I have maybe some questions here for the oh, my bad. Hey, I did not put question for okay. Probably I mixed it with the lung cancer. Let's see. I'm going to check. If I did not put question there, I'm going to find a way to put it on the page. So sorry about that. So moving on to lung cancer, very easy. So this is the commonest cause of cancer death in the US. Once they say that was the most likely cause of death that is going to be a cancer that is a killer, is lung cancer. Lung cancer is a killer. Female, male, anywhere. US, male or female, it is lung cancer. So what are the risk factors? Smoking, high yield. Cannot forget that. We know that already. Except the bronchoalveolar carcinoma, which is more like a pre-malignant form of adenocarcinoma of the lung. So the bronchoalveolar carcinoma. So it occurs in people that are not smoking sometimes. Radon exposure. So after smoking, radon is the next you want to remember. Radon exposure is one of the common cause of lung cancer. Then asbestosis. Even though it's a cause of mesothelioma, but it commonly causes lung cancer. What are the types? We are not wasting too much time. We already know this. You categorize them into the small cell or the non-small cell. Small cell or the non-small cell. So for the small cell, what's their location? Most of the time they are central. The small cell is central in location. And they are very much associated with smoking. Most of the time they are smokers. They are undifferentiated. They don't look like the normal lung cells. That's it. They are different. In fact, they appear small, dark, round, blue. Yeah, which is not what you find in normal lung, cell, normal lung tissue. They don't appear small, round, blue. So that's why once you see a small, round, dark blue cell on your histology, you are thinking of small cell carcinoma as the likely cause, because that is an undifferentiated tumor. It does not look like the parent cell. It has a very high tendency to metastasize. That's why the prognosis is poor. They can metastasize. They go to the BLB, the brain, the liver, the bone. What are the paraneoplastic syndromes they are going to show you? That is what they are going to show you in your exam. Don't forget the A's. ACT, ADH, ACT, ADH, ACTH, ADH. So, ACTH producing tumor, small cell. ADH producing tumor, small cell. They can also have the Lambert-Eaton myasthenic syndrome, we know. So people having antibodies against the presynaptic calcium channels, having Lambert-Eaton. I kind of be asking us how Lambert-Eaton is going to be like an embarrassment, asking us how Lambert-Eaton presents. So we know how to distinguish it from myasthenia. We know the antibody I share with the myasthenia. We know the antibodies I share with the Lambert-Eaton. We know the presentation, and we know the other things to look out for. So aside the Lambert-Eaton, they can also have antibodies against some neuronal components. So which is a paraneoplastic myelitis and a paraneoplastic encephalitis. Please, can we still hear me? Because I kind of pressed something on my mic. Hello?
Yes.
Okay, good.
Yes.
So the paraneoplastic myelitis, you just see that somebody having cancer, weight loss, cough, emesis, chest pain, recurrent infection, and they tell you that the person is having problems with cognition. They're having problems with speech. They're having seizures. You want to think of your paraneoplastic encephalitis. Some of all these things, cough, weight loss, hemoptysis, and having difficulty moving, lower limb paralysis, incontinence, sensory loss, you can think of paraneoplastic myelitis, from your sickle cell, from your small cell carcinoma. Histology, the Kochiski cells, small and dark blue cell, don't forget them. And of course, from your staining, you can see the NSC, neuron-specific enolase, chromoganin A, synaptophysin. Very important stuff. It is not only small cell that is from the Kochiski cells, your brachial carcinoma too. This I usually forget the name. I don't know why. Your brachial carcinoma tumor rather. It's also from the Kochiski cells. So that's that about small cell. We are going to talk about the treatment. What you just want to do, identify, is it metastatic or not? If it's metastatic, just give radio and chemo, cisplatin based combination. Chemo, cisplatin based combination with your radiotherapy. If it's early, radiotherapy is sufficient. But most of the time, because of their bad prognosis, they have metastasized before you even know. So you are going to be giving your chemo and your radio. For the non-small cell, adeno, what is the position going to be like? Peripheral. They will tell you that the position of the tumor is peripheral if they want to be generous. The classic individual demography is that they are going to be a female non-smoker. A female non-smoker, think of adenocarcinoma. A female non-smoker, think of adenocarcinoma. Its own paraneoplastic stuff includes hypertrophic osteoarthropathy. It can be driven by some mutations, your KRAS mutation, your EGFR mutation, and your ALK translocation. So this is where the targeted therapy comes into play. So you might want to be giving KRAS inhibitors, EGFR inhibitors, ALK inhibitors to treat it. I talked about the bronchoalveolar subtype, which is adenocarcinoma in situ. So the tumor here is just growing along the alveolar septa. It hasn't crossed the basal membrane, and it's more like adenocarcinoma in situ. You don't need to worry yourself about that. Once you do your histology, you are not going to be seeing small round blue cells. Instead, you are going to be seeing glandular cells that stains with mucin. They are more like the lung cells. They appear glandular and they stain mucin. The squamous cell carcinoma is just like small cell. They are both central. But what you are going to be looking for in squamous cell is cavitation. You see, once you see cavitation and you are thinking of cancer, please just go and shade your squamous cell and you move. They can give you the paraneoplastic manifestation, which is what? Your parathyroid hormone related protein. It is going to be elevated. PTH is not going to be elevated, but your parathyroid hormone related protein or peptide is going to be elevated. It is strongly associated with smoking. In fact, it is more associated with smoking than small cell. If you are confused between what to pick squamous for the smoking. Yeah. If you do histology, what are you going to see? Keratin pearls. Keratin is related to squamous, so keratin pearls with intercellular bridges, classic for your squamous cell. You are not going to be seeing glands with mucin. No. You are not going to see small round blue cells. No. See, keratin pearls with intracellular bridges. What about your large cell carcinoma? It's peripheral too, just like adeno. What you just need to look out for is your pleomorphic giant cells. You think of large cell carcinoma. For your bronchial carcinoma tumor, this one is very common in young people. Young non-smoker. They'll be young, 20 years, 27 years. They are not smoking and they have bronchial carcinoma tumor. Most of the time, the presentation is due to mass effect, occlusion of the bronchial airways. And they cannot clear out mucus, so they have repeated infections, bronchiectasis and the likes. And sometimes, because of the carcinoid effect, they can be releasing serotonin, histamine, which can cause the flushing, the diarrhea, and wheezing. So if you see somebody as you are suspecting lung cancer and the person is having flushing sensation, the person is having diarrhea and wheezing, think about bronchial carcinoma tumor. So it's going to have the same presentation like small cell. They are going to have small round blue cell. If you do your staining, chromogranin here will be positive, non-specific enolase will be positive, synaptophysin is going to be positive. Yeah. So we have talked about the presentation, the cough, hemoptysis, dyspnea, all these things. Recurrent infection, recurrent pneumonia, in which category? Anybody? Recurrent pneumonia, which category? Anybody remembers when I said it now? Recurrent infection. We are not following me.
Sorry, what's the question?
So
What's the question?
lung cancer with recurrent pneumonia. Which subtype?
Which recurrent pneumonia? The bronchoalveolar type.
Bronchial carcinoid.
Yeah, the bronchial carcinoid because of obstruction of the airway. Mass effect. Think about that. So, they can have crackles because of the pneumonia. They can have atelectasis. We know that you can have obstructive atelectasis. So, that's why they can have atelectasis. So, but just watch out for the other cardinal signs to nail your diagnosis. That's what I would say. Squamous, watch out for the cavitation, watch out for the keratin pearls and the intracellular bridges. So, what are the complications? Sometimes you can have the tumors occurring at the apex of the lung, and that's what you call the superior sulcus tumor or your Pancoast tumor, apex of the lung, and they are going to be compressing on tissues or structures that are adjacent, the vessels, the nerves, majorly the vessels and the nerves. So, what nerves are we talking about? The first one you don't want to forget, the brachial plexus. Brachial plexus comes from the neck, so definitely, it can be compressed, particularly the lower part, your CH to T1 component. And the first symptom you are going to see the question pointing out to is what? Shoulder pain. So somebody that has something that looks like lung cancer and the person is having shoulder pain and referred pain to the arm, think about brachial plexus compression. It can compress on the paravertebral sympathetic chain and the inferior stellate ganglion because they run downwards from the hypothalamus. It extends into the thoracic region before it now moves upwards. If you have that image, you can Google, you see it. The sympathetic fibers are coming from the hypothalamus directly, and they run downwards to the neck and upwards again to go to the face. So where they are running downwards in the neck, they can be compressed, particularly the T1 component, in the stellate ganglion. So that's why they can have compression of the sympathetic nerve. And when the sympathetic nerve are gone, you can have Horner syndrome, right? Because everything about Horner syndrome is just loss of sympathetic activation. So to the face, loss of sympathetic activation to the face. So the individual is going to be having unopposed parasympathetic activation, which is meiosis. They are going to be having ptosis. The ptosis is due to paralysis of the levator palpebral superiority muscle. Anybody, true or false? What muscle is causing the ptosis?
Yes.
Dr. Antonia fell for my trap.
Hmm?
So I said that the ptosis in Horner syndrome is due to loss of activity of the levator palpebral superiority muscle.
No.
What
No.
supplies the
That
levator
one
muscle?
is
What supplies the levator
third,
muscle?
the third nerve.
The third nerve. So this is not sympathetic. So why are they having ptosis? So the reason why they have the ptosis is because there's another muscle that assists the levator that I call the superior tarsal muscle. The superior tarsal muscle is supplied by your sympathetic chain, by sympathetic nerve. So that's why they have the ptosis. So although the ptosis might not be as severe as the ptosis of when you have oculomotor nerve palsy. Yeah. So then the anhidrosis, because you need your sympathetic nerves, to supply the sweat glands. So there's going to be anhidrosis. So don't forget that. I know you know all this. The superior vena cava can be compressed. And how you are going to differentiate superior vena cava compression from brachiocephalic compression, because both of them can occur in lung cancer, is that one is going to be unilateral, the other one is bilateral. So, excuse me. The superior vena cava one is going to be bilateral because your right and left brachiocephalic trunk empties to form the superior vena cava. So you're going to be having blood pulling upstream to the right and left brachiocephalic, going back to the internal jugular, the subclavian. So there's going to be edema of the face, edema of the chest, plethora of the upper limb. They cannot breathe, difficulty in breathing and the likes. So superior vena cava syndrome. Just identify is it unilateral or bilateral. If it's bilateral, go for SVC. If it's unilateral, go for what? Which one do you go for if it's unilateral?
Brachiocephalic.
Brachiocephalic. Nice. So this is an histology showing the glands. So if this is the glands, so what is this representing? What form of lung cancer is this? If it's glandular, adenocarcinoma. So this is the one that is showing like infiltrate with some areas of cavitations, necrosis. So if you are saying necrosis, cavitations, what are you thinking of?
Squamous cell.
Squamous cell. Good. So they can also have compression of the recurrent laryngeal nerve, and there's going to be hoarseness. They can have many paraneoplastic syndromes, and we have them. We just need to know a few of them. Don't need to know everything. The common ones: Cushing syndrome, ACTH, ADH. ADH and ACTH is small cell. Your PTH-RP is from the what? Squamous cell. Gynecomastia is a large cell. Gyne, big breast, and large cell, big cell. So it's due to the HCG secretion effect of this large cell. The skeletal hypertrophic osteoarthropathy, we've said this for the non-small cell, particularly which one? Anybody remembers? Particularly.
What's your question?
Hypertrophic pulmonary osteoarthropathy. So
adenocarcinoma.
So the neuromuscular, just think about small cell. The one that causes the neuro, just like I've said. Your cerebral degeneration, paraneoplastic encephalitis, paraneoplastic myelitis, Lambert-Eaton, think about this small cell. All of them can cause dermatomyositis, although dermatomyositis is very common for ovarian. Cardiovascular, the migratory thrombophlebitis and the non-bacterial verrucous endocarditis is very common with the adenocarcinoma, because the mucin that this guy is secreting can trigger the coagulation cascade, and it can lead to non-bacterial verrucous endocarditis. What other name do you call this endocarditis from our CVS? Have we done the CVS?
Mm-hmm.
So what other name do you call that?
Non-septic, um, non-septic endocarditis.
Non-septic. Well, that's correct. Non-septic.
Yeah.
Yeah. So you call it the Liebman sac,
In,
endocarditis. And what is peculiar about
in,
it?
essence,
What is peculiar about
in
it?
essence, there's no microbial involvement.
No
It's just
microbial
the
involvement.
platelet blood and the fibrin.
Yeah.
That's it. Yeah.
The platelet, the fibrin, the immune complex, right? So it's very common. People with SLE, people with pancreatic adenocarcinoma. So you have to do something. What do you have to do in these people? You have to give them something because of risk of something. I'm brushing up our CVS with us. That is brushing up of CVS. I will start calling names
See,
now. People are not talking.
is it
Doctor, huh?
Is it anticoagulant?
Yeah, they have a high
Yeah.
risk of disclodging. So
Mm-hmm.
anticoagulate them. For the migratory thrombophlebitis, you just see that there's history of, you know, uh, tender, palpable cord-like feeling. From the legs, it's going to the arms, different places. So it's due to the fact that you have inflammation of the veins. So you have this tender, cord-like, palpable feeling, of the veins, and with tenderness, signs of inflammation. So you think of migratory thrombophlebitis, and it's moving from one part to the other part. So it's likely that this person has a pancreatic adenocarcinoma. Most of the time, it's pancreatic adenocarcinoma. So it can also occur with other form of adenocarcinoma, like lung adenocarcinoma. Just know that adenocarcinoma is going to be there. Then all of them can cause anemia, DIC, eosinophilia, so that's that. How do you want to investigate this patient? The first thing you want to do is do your X-ray or your CT. Anyone you can lay your hands on, do it. Then, once you can identify that lesion and it's looking suspicious for a cancer. For example, you are seeing cavitations, area of necrosis. You are seeing like a mass occluding the bronchial airways. Or to think, okay, this is likely to be a malignancy. Then, depending on the situation, depending on the position, that is going to guide what you are going to do next. So, if it is peripheral in location, you are going to go peripherally in your approach, and that is when you do your fine needle aspiration. So you go from outside, fine needle aspiration, and you biopsy it. If this is a lung and this is a airway, right, and you can see a tumor here peripherally, you just do your fine needle aspiration under CT guidance, you biopsy it. Simple. If it's here, of course, imagine the thickness that you are going to penetrate to go and be biopsying. So instead, you go transbronchial approach and you do your bronchoscopy, you do your biopsy, or you do your brushing. So if it's central, do your bronchoscopy and do your brushing or biopsy. If it's peripheral, do your what? Fine needle aspiration under CT guidance. Once you do that, and you make your diagnosis that, okay, this is malignancy, this is lung cancer. The next thing you want to do is to stage it. Because don't forget, we said that BLB spreads to the brain, the liver, and the bone. So do your PET scan, CT scan for your staging. How do you treat? So most of the time, if it's malignant, most of the time, maybe they will give you like small cell or squamous cell. But most of the time, what you want to do is just to identify if it's malignant, if it's metastatic or not. So if it's metastatic, you have to do your chemotherapy with your radiotherapy. But if it's not metastatic, you can do your what's it called, your radiotherapy only. The approach to the management actually depends on the type, but I don't think it's within the scope of our step 2. Like what I've said now is what you need to know. If it's metastatic, give your chemo and your radio. If it's not metastatic, you can give your radio. But for example, if somebody has large cell, it's amenable to surgical resection. So you can try to give your neoadjuvant to reduce the size, then you try to remove it. Or sometimes you can go in, if it's not too big, you go in, you reset it, then you give your adjuvant therapy after you have, resected. So, but the one I've said earlier is the management for small cell. So, just identify is this metastatic or not. If it's metastatic, just give chemo, radio, cisplatin based combination. If it's not metastatic, give your radio. So, the chemotherapy, we know what they do. Targeted ones are the ones that you are targeting some particular drivers. EGFR, ALK, KRAS, in which tumor?
Adenocarcinoma.
Adenocarcinoma. Then you can also give immune checkpoint modulators. You want to give your PDA ligand blockers, your PD blockers, your CTLA blockers. Once you block all these things, your T cells will be strengthened to fight and attack the tumor. I don't want to go into the details. That's covered in our immunology already. And we have a lot of stuff to cover. So let me see if we can solve one or two questions here. And okay. I just hope I put solitary node here. A 43-year-old man comes to the office due to several weeks of nagging left-sided chest pain that worsens with deep inspiration. He has also had a progressive non-productive cough and dyspnea. The patient denies fever or chills. He was diagnosed with non-Hodgkin lymphoma in his early 20s and was treated with chemotherapy and radiation. Blood pressure is 144/90, pulse is 92. The patient appears thin. Examination is otherwise normal. Chest X-ray is shown. Oh my god, I don't have the chest X-ray. Do I have it? Let me see. Okay, I think I have it. Okay, yeah, I do have it. So can we see this chest X-ray? Hello everyone.
Yes, you can.
Yes.
So can we see the tumor?
Yes, on the left side, kind of a coin.
Yeah. So what do you want to do for this patient after you have done this? You have done this imaging. What's the next step you want to do?
Take biopsy.
How?
The size. Determine the size.
How?
CT guided.
What?
CT guided.
CT, non-partial CT.
Yeah. So CT guided finally do aspirate. Why are we sounding, Dr. Antonio? Are you tired? Why are you sounding?
I'm not. I have this upper airway that is like crackling my voice.
Oh, sorry about that. So sorry about that. So we need people to also be talking so that Dr. Antonio doesn't have laryngitis. We are going to talk about laryngitis. So if somebody is talking too much, they can have laryngitis. Dr. Olushola, I need you. Dr. Kumi, Dr. Miriam, I've not been hearing your voice. You have just been.
I just spoke now.
Okay.
I just spoke.
So, yeah, so that's that about lung cancer. So let me see if I have another question. A 48-year-old man with 30 pack year history comes to the physician.
You're not serious. I really didn't answer the question for the last one.
Yeah. We already said it's lung cancer, right?
Oh, okay.
And you biopsy using your
CT.
your fine needle aspiration, your CT guidance. Can you see my screen now? Because
Yeah, I can see your screen.
Dr. Antonia, what about you?
I can see your screen. Yeah.
A 48-year-old man with 30-year pack history comes to the physician for follow-up examination 6 months after a chest CT. Shows a solitary 5mm solid nodule. Okay, this is a nodule question. Thank God. I know I will not do that. I will look for it. So, 48-year-old man, 30 pack year, smoking, comes for follow-up after 6 months. Comes for follow-up examination 6 months after a chest CT shows solitary nodule, which is 5mm in the upper lobe of the right lung. Okay. The follow-up CT shows that the size of the nodule has increased to 2 cm. Okay. Ipsilateral mediastinal lymph node involvement is noted. A biopsy of the pulmonary nodule shows small dark blue tumor with hyperchromatic nuclear and scars cytoplasm. Cranial MRI and skeletal scintigraphy shows no evidence of MET. Which of the following is the most appropriate next step in the management? You know,
Radiation.
you know, wait, wait. We know that the approach is to what? The first thing you want to do is to have your diagnosis, right? Have your
Yes.
diagnosis. So, what is your diagnosis?
Small,
Small cell
small cell.
carcinoma.
Small cell
It's a small
carcinoma.
cell carcinoma, yeah.
Yeah. So, uh, I'm coming, Dr. Antonio, just a minute. Okay. Okay. Yeah. So, I'm with you. So, this is a small cell carcinoma because of um, what's it called? Uh,
Small dark
the
blue
small
tumor
dark blue
cell.
tumor cell and the fact that this person is a smoker. Yeah. So, are we going with radiation? Yeah. Okay. Yeah. I know we
Yes.
understand what I've said, but the answer will not be radiation.
Yes.
The reason why the answer will not be
Yeah,
radiation.
this
Okay, I'm listening. Somebody wants to say something.
yeah, why I chose radiation, they said the MRI and the skeleton show no evidence of other metastasis. So I assumed it's like in the early stage because there's no metastasis. But I know you said it metastasizes early most times. And
Yes.
if there are metastasis, you do chemo and radio.
Yes. So something I forgot to mention is that you see, look at the statement, Dr. Antonia, shows no evidence of order. So that means that there's already a met. Clinical MRI
Oh,
and skeletal shows no evidence of order. Do you get?
metastasis.
So the fact that it has involved the lymph node is already going beyond the
Oh,
lungs.
okay, yeah.
So you have to give the
Chemo and radiotherapy.
so so that's the way it works. Okay, so I know that you understand. It's just that that question is a little bit ambiguous. So just pay attention. The fact that it has gone beyond the lungs is already going. It has already metastasized to the lymph nodes. So still give your chemo and your radiotherapy. Okay.
Okay, so Dr. Babola, I have a question. So
Yeah.
when person comes in and shows a nodule and you ordered for a previous, assuming there's a previous X-ray done,
Mm-hmm.
and you compare it,
Mm-hmm.
and the size remains the same,
Yeah.
do you need to monitor the serial CT?
No. Don't monitor. Just leave it. Reason be
Okay.
that the fact that you are doing your serial CT, you are further exposing that patient to radiation. So
Yes.
you can even propagate the transformation of that nodule to a cancer. So it's better to just leave it. So
Yeah, depending on what the
y-
last X-ray is done.
yes,
Okay.
yes. If the nodule is old, the side is stable, greater than 2 years, no further evaluation is required. Just leave that person.
Okay.
Don't need to further.
Okay. So what if it's a new nodule?
Yeah. So if
And the
it's
size?
yeah, yeah. If
Go
it's a
ahead.
new nodule, you're not even worried about the size again. Once it is a new nodule, that okay. What you mean by the new nodule is that you are looking at the nodule now, and you ordered a previous CT or a previous X-ray. You are not seeing anything there. So that means that it is a new nodule. Do you understand? So in that kind of person, you order your what?
Mm-hmm.
Your CT next. You do your CT scan next. Provided that the scan that you're actually using to see it initially was the X-ray. That is okay. A patient comes in, you did the chest X-ray, and you saw a nodule, and you requested for previous X-ray. There's no nodule. So you know that this is a new nodule. So what do? Order a non-contrast enhanced CT scan of the lung. Do you
Okay.
understand? To assess for the risk of malignancy.
Okay.
Do you get it?
Yes.
So I'm going to look for questions on that
So
nodule.
if
I'm with you. I'm with you.
so if it is intermediate and the nodule size is between 5 to 7, you do your serial monitoring.
Serial monitoring. Yeah, serial monitoring. So because that's big. But if it's 8, just go and do your PET or your biopsy to look for whatever is there. But you know that you cannot leave the patient alone because 8 is significant. So even if you do your biopsy and you're not seeing malignancy, still do serial CT scan. But if it's malignant, surgical resection. So it's a little bit confusing, but Just take some time to look at it again at our free time. We definitely figure it out. So moving on to the respiratory tract infection, we're not going to be wasting too much time here. Pneumonia, we already know epiglottitis tract group. All these ones is plantain chips to us. We know them very well. Pneumonia is something we are going to see in our exam. It's very common, and it has 3 different causes: bacterial, fungal, and viral. This is an infection of the parenchyma of the lungs. That's what you call pneumonia. And there's so many risk factors, immunosuppression, um, alcohol, smoking, people with COPD, all of our manner of things. And what's the classic presentation? Fever is the number one thing. There's going to be fever because this is an infection. You expect fever. And for the classic pneumonia, you expect what? Productive cough. We know that this stuff is what I've been hammering from our step 1. The cough has to be productive. For it to be like classic pneumonia, they have to have a productive cough. And the sputum that you are producing, the color can also tell you about the likely organism. So if it's yellow, if it's green, think about pseudomonas. If it's dusty brown, you can think about your strep pneumo and the other one. So they can have dyspnea, they can have night sweats, bloated chest pain. That's just there. Watch out for the atypical presentation. Very important stuff. That is what is going to differentiate you from other candidates. You know how classic pneumonia should present, and you also know how atypical pneumonia will present. You are definitely going to be thinking differently with respect to the underlying organism. So, what are these atypical presentation? Instead of having fever, they can tell you gradual onset. Okay, look at the cough. Is it productive? This person is having dry cough. Oh, atypical pneumonia. This person is having some constitutional symptoms like headaches, myalgia, sore throat, GI symptoms. You can never think of strep pneumo, cleb pneumo, staph aureus, as a cause of pneumonia, and you are picking myalgia, GI, sore throat. That would never be correct. Or the cough is not productive. That would never be correct. So, once you are seeing the gradual onset of fever, dry cough, headache, myalgia, sore throat, GI symptoms, think about other things. GI, you can think about Legionella. The myalgia, you think about influenza, sore throat, influenza. Headaches, you can think about the mycoplasma, the fact that it's not productive in the mycoplasma. All of them, they can have this kind of presentation. So, the what are atypical? These are the organisms: your chlamydia, pneumonia rather, your mycoplasma pneumonia, and your Legionella pneumonia. Most of the time, Legionella, they will have GI symptoms, and they will tell you that the person has cruised a ship, or the person is in the office, receiving too much AC. That's that about Legionella. Mycoplasma, they can help you. The person is staying in barracks, daycare, just some close compartments, military barracks, dormitories. They can tell you the person is having some rash. Erythema, what? Anybody? Erythema, what?
Nodosum. Erythema nodosum.
Erythema nodosum for mycoplasma pneumonia. Are you sure?
Yeah.
We are.
Oh no.
This thing.
Erythema multiforme.
Erythema multiforme. Very important stuff. So, if you do your longer examination, what do you expect? The broker breath sound or the breath sound will be increased. Please ignore this. Broker breath sound or increased breath sound. They can have rails from crackles. They can have dullness to percussion, right? Because of the consolidation. They can have a gophony or increased tactile fermenters because the consolidated lungs have a high tendency to transmit high frequency sounds. So if you tell them, say, E, it's going to be sounding, hey, E, hey, hey has higher pitch than he. So that's a gophony. Then if you do your tactile fermenters too, it's going to be elevated. So that's suggestive of consolidation from the pneumonia. So don't forget that elevated tactile fermenters, a gophony, dullness to percussion, and increased breath sound or bronchial breath sound, rails or crackles are all suggestive of pneumonia. You have a patient having fever, productive cough, dyspnea, you do your examination, crackles, donors percussion, the rails, increased tax affirmators, you are thinking of pneumonia, the next thing to do, order your chest X-ray. Order your chest X-ray. That's the next thing you want to do. And if you don't see anything on your chest X-ray, but you are still having a high index of suspicion, what do you want to do? A CT scan. What CT scan do we think we are going to order? Contrast or non-contrast? From what I've explained. Anybody?
Contrast.
No.
Contrast.
Because you want to see the parenchyma. When I said we are doing non-contrast for nodule, I said we want to see the parenchyma well, right? So, don't you want to see the parenchyma well in pneumonia? Hello, we are not talking. Hello?
Chief, please
Yes.
can you go over it again?
Hello. Is it my network?
Is he talking or is me that can hear?
Hello? Is it better now?
Yes,
Hello?
Dr. Baba.
Yeah.
So, I
Yeah.
said that
Yes,
the
we can
reason
hear you now.
I said that the reason why you are ordering
We're not
in
seeing your screen. Just seeing you now.
Hello, can you see my screen now?
Uh,
Hello?
I'm not seeing anything. Oh.
Wow. But I'm already.
We are seeing your cursor move.
Is it better now? Because I'm already sharing the screen.
We are only seeing your cursor move. We are not seeing. You are not projecting the first aid yet.
Like, can you see my first aid now?
Oh yeah, yes.
Yeah, but you guys can see my screen now. Yeah, so that's
All
the
right.
most important thing. Okay. Yeah, so I said the reason why um we are doing a non-contrast CT scan is that we want to see the pulmonary parenchyma. For example, someone that has a pulmonary nodule, we want to see that nodule with respect to the pulmonary parenchyma. How is it delineated from the parenchyma? In someone that has PE, are you interested in seeing pulmonary parenchyma? You are looking at the vessel. There's no, you don't have any business with the parenchyma. But someone that has pneumonia, are you interested in the parenchyma or not? Hello?
yes.
Yeah.
Yes.
So if you are interested in the parenchyma in someone that has a pneumonia, which CT are you going to order? Is it going to be a contrast enhanced or a non-contrast enhanced?
Contrast enhanced.
Like what I'm saying is, if you put your contrast,
Oh, we didn't understand. Not contrast.
you are not going to see that parenchyma well. Your contrast is going to
Oh,
obliterate that parenchyma. So that's why when
okay.
you are doing pulmonary nodule evaluation, you use non-contrast because you want to see the parenchyma, right? So,
Okay.
so for
Oh,
pneumonia, order a non-contrast CT so that you can see the parenchyma clearly, and your contrast will
no
not occlude your
contrast.
view. So, if you have this algorithm at the back of your mind, you can think of any other thing. Once they ask you any condition, like what are you going to do, you know. Just ask yourself, am I interested in looking at the parenchyma well in this condition? If I'm interested, I have to do a non-contrast. If I don't give a damn about the parenchyma, it's only the vessel, you do your contrast. For example, someone has a PE, it's a contrast. But pneumonia, nodule,
Okay.
any other thing, do your non-contrast CT.
Okay.
So
That's
how
it.
do
That's
you
a good.
so how do you want to manage them? So you have to look at the setting. Is it an hospital setting or a community setting? So most of the time it's going to be community setting. The next thing you want to do is to calculate your COP 65 score, right? Your C for your confusion, your U for your urea level greater than 7 or 20, depending on the unit, your R for the respiratory rate greater than 30, your B for the blood pressure less than 90/60, then the H 65 years. So anybody that is more than 65 years has a BP less than 90/60, respiratory rate more than 30, urea more than 7 millimole per liter or 20 milligram per dl, confused, you have to admit. Anybody that has any of the, like all of these, admit. So what's the scoring system? You assign a score of 1 for each of them. 1, 2, 3, 4, 5. So if anybody gets a score of 0 to 1, it's not very severe. 0 to 1 is not severe, so you treat as outpatient. If the person has a score of 2, hospitalize. If the person has a score of 3, consider ICU care. Do you understand that?
Yes. So is the BP, is it less than 90/60 or greater than
No,
90?
less than 90/60. It means it's bad. Do you
That's,
understand? Like it's bad. So
yes.
less than 90/60.
Yeah.
So
Yeah.
so that's the first thing you do, right? So once you identify your scoring, then you want to stratify according to that scoring, and you want to treat accordingly. This is very important because it's going to be part of your answers. It's going to be part of your option. Hospitalize and place on this. Admit to ICU and do this. Treat as outpatient and do that. So you have to know what you are going to do based on your COP 65 stratification. Provided you identify that, okay, this person is presented with community acquired pneumonia. Okay, so this is staining. Now, the mistake most people make is that they focus on the red. You see, the assignment you are going to do first is to look at the organism. Look for the organism in your stain. The organism in this stain are these tiny guys, right? It is not the background stuff. The background red you are seeing is the counter stain. That's your safranin or something. So some people just see that red and be like, this is gram negative now. No, you look at the tiny organism. The tiny organism here is appearing like what color? Anybody? Can we hear me?
Blue,
It's
purple.
appearing blue or purple. So this is going to be gram
Yeah.
positive, right?
Positive.
Yeah.
Mhm.
So and they are kind of paired together. So this gram positive cocci and you pick your strep pneumo. Very easy stuff. This is gram positive in clusters. This is your staph aureus. You don't have to be a genius to know all these things. Now, the atypical ones, they are very difficult to culture, so you only consider them when the clinical suspicion is very high. So so let's go to the drug. Okay, you have to talk about this. The typical bacteria, we know all these things: strep pneumo, influenza, moraxella, staph aureus. The atypical ones are the legionella, the mycoplasma, the chlamydia, and of course the viruses, influenza, parainfluenza, all of them. And there are some risk factors associated. Aspiration, think about the anaerobes, think about the gram negatives, because they can aspirate from the GIT. So anaerobes and the enterics. For the alcohol, think about CLEB. CLEB is the number one in alcohol. CLEB is the number one in alcohol. So you can have CLEB, they can also have strep pneumo. Because they can aspirate, they can also have the horror anaerobes. COPD, think about all of them. COPD can cause all the causes of typical pneumonia can be implicated in COPD. So your strep pneumo, your H influenza, your moraxella catarrhalis, pseudomonas, because of the structural disease, they cannot develop, pneumonia, in COPD. So, so that's why, don't forget, what are the vaccination you want to give a patient with COPD?
Influenza vaccine and pneumococcal vaccine.
You want to give the monthly influenza vaccine, Abi?
Yearly.
You want to give the annually influenza vaccine, and you want to give your one-time strep pneumo vaccine. Your
Strep
PPV
pneumo vaccine.
15, plus PPSV 23 or your PCV 20. Good. Exposure to animals. Think about the birds. Avian influenza can come from birds. Chlamydophila psittacosis can come from birds. People that get exposed to bird and bat dongs can develop histoplasmosis. Rabbits, Francisella, Coxella bonnetti in farm animals. Particular people that butcher them, Coxella bonnetti. HIV. Think about pneumocystic. Think about histoplasma. Think about aspergillus. Think about tuberculosis. Those are the common ones. Strep pneumo too. HIV, immunosuppression. Strep pneumo. That's why, the algorithm for vaccination against strep pneumo is wide. People with immunosuppression, people with COPD, people with functional asplenia, people with cochlear implant, people with air trauma, a lot of stuff. So HIV is bad. Vaccinate them against strep pneumo. Mycobacterium tuberculosis, opportunistic infection, hemocystic, very well explanatory, like aspergillus, histoplasma. In fact, most of the time, people with histoplasmosis will not develop anything until they have HIV or immunosuppression. They are asymptomatic. Very important you remember that. So if you see somebody developing histoplasmotic pneumonia features, know that there's a background immunosuppression. Recent travel. Have you gone on a cruising, boat cruising or hotel Legionella? And don't forget, in addition to the pneumonia-like feature, what did I say they are going to be having again? Anybody remembers?
GI symptoms.
GI symptoms. Very good. GI symptoms. They can have CNS symptoms. Very good. Please, let's be paying attention. Please. All these things are going to help us. Very important. Structural lung disease. Just think about these three. If you can, remember Burkidoria is good, but the ones you can never forget is Pseudomonas and Staph aureus. And what they are talking about here for the structural lung disease is majorly cystic fibrosis and sometimes bronchiectasis. But cystic fibrosis comes to mind once they talk structural lung disease, and Pseudomonas in adults, Staph aureus in younger. Burkidoria too is common in cystic fibrosis. Post-viral, so just think about staph, strep. Don't worry about that. Injection, don't worry about that. Oh. So, how do you treat? So, you have to give empiric till you obtain your gram staining, and your culture to test the particular organism and the sensitivity. But before you do that, start the patient on the empirics, and they want you to know the empirics so that you can save the patient as early as possible. For the immunocompromised patient or patient with structural lung disease, you must never forget to add an antibiotic that cover against Pseudomonas. It is a crime. It is a crime to ignore that. So somebody comes in with bronchiectasis, somebody comes in with cystic fibrosis, or the person is immunocompromised, and you are not giving antibiotic covering against Pseudomonas, you have done nothing. So your anti-Pseudomonas beta-lactam is very important, like your piperacillin, tazobactam. Or you can add a respiratory fluoroquinolone or a macrolide to it. So I am going to talk about them in detail in this table. Now, you don't need to cram everything that is here. What you just need to know is that, okay, I have done my COP 65. This patient is having a score of 0 to 1. So that is what type of treatment? 0 to 1 is what? Outpatient treatment. So 0 to 1, outpatient. The person is, less than or equal to 65 years, right? No problem. And the person is healthy. So a man that is 40 years, I've done my COP 65 scoring, is having a score of 0 to 1. What I just want to do for that person is just to give the person the MAD. You can call it MAD, you can call it AMD, anyone. MAD, MAD, macrolide, doxycycline, or amoxicillin. Any one of these three, your macrolide, your doxy, or your amoxicillin, is going to cover for the suspected. You don't need to cram all these organisms. Nobody is going to ask you. But you must know the empiric drugs you have to give them. So it's going to cover for all these. The atypical ones and the typical ones, all of them can be, the cause of pneumonia. So you give them the MAD, any of the MAD. If the person is more than 65 years, or the person is having comorbidities, right, then you still have to add something to all this MAD. So what I would advise you to just have at the back of your mind is that once you are saying that, okay, the individual is more than 65, you have done your stratification 0 to 1 outpatient, right? and you look at the age, more than 65, or the person has comorbidities like COPD, heart failure, renal failure, any of them, any comorbidity, then you don't give only the MAD. So you have to give a beta-lactam plus a macrolide, or a monotherapy of a respiratory fluoroquinolone. I can assure you, once you can put that at the back of your mind, you can never have a problem with pneumonia. Once you have done your stratification, and in addition to that, you are seeing age more than 65 or like comorbidity, renal failure, diabetes, liver, anything, you have to give a beta-lactam plus a macrolide, or you give fluoroquinolone, respiratory fluoroquinolone monotherapy. So if you are saying a beta-lactam, we mean probably you are giving cephalosporin like ceftriaxone, or you are using your amoxicillin clavulanic acid with your macrolide, or you are giving your respiratory fluoroquinolone monotherapy only. So like level, like moxi, fluoxazine, any one of them. Just give one, or you give a combination therapy of your beta-lactam with your macrolide. Are going to be fine. If the person requires hospitalization, now this is not 0 to 1. This is what score now. Requires hospitalization to the medical floor. What score is that? That's a score of 2. It's still the same thing as your initial one. So either you give a beta-lactam with a macrolide or a single respiratory fluoroquinolone treatment. We can see that it's easy, very easy. Then the third category is people that they require ICU. So someone that has a score of 3 and above, ICU treatment. So now in this situation now, you can either give your beta-lactam plus your macrolide, or your beta-lactam plus respiratory fluoroquinolone. Do we understand that?
It's confusing. Maybe we can take it again.
So if it's 0 to 1, patient is less than 65, there's no comorbidity, give your MAD. Any of your MAD. If the patient is 0 to 1, outpatient, more than 65 years, or the person is having comorbidity, so you have to add something to your MAD. Either you give beta-lactam plus macrolide or respiratory fluoroquinolone monotherapy. That's all. If the person is requiring hospitalization, score of 2, not outpatient, you have to give your beta-lactam plus your macrolide or respiratory fluoroquinolone, just like the one we are doing for somebody that requires outpatient but more than 65, or the person is with comorbidity. The same thing with hospitalization. Your beta-lactam plus macrolide or your fluoroquinolone monotherapy. If the person requires ICU treatment, score of 3, you are taking to ICU. Beta-lactam plus macrolide, you are saying it again, or beta-lactam plus fluoroquinolone, not fluoroquinolone monotherapy, but beta-lactam plus fluoroquinolone. Do you understand? Hello?
Yes. So it's either that MAD, either of them, and then beta-lactam macrolide or the respiratory fluoroquinolone for group 2. Then group 3, either the beta-lactam or macrolide respiratory fluoroquinolone, right?
No, you have to, like for the group 3, you are adding, you must add beta-lactam plus macrolide or beta-lactam plus fluoroquinolone.
Okay.
For the ICU. Now, that is for community acquired. It's coming from the community, and you are either treating as outpatient, you are admitting to medical floor, or you are admitting to ICU. If the person developed that pneumonia in the hospital, that is, the person developed the symptom after 48 hours of admission, that is hospital acquired. Now, because Pseudomonas is a problem in the hospital, and they are drug resistant. So that means that once you see that, okay, this person developed hospital acquired pneumonia, you have to give an anti-pseudomonal agent to whatever you are going to be giving. Anti-pseudomonal agent must start it. So your piperacillin tazobactam is on standby for hospital acquired. Now, you now evaluate the patient. Does the person has structural lung disease, or the person is immunocompromised? Then you have to add another anti-pseudomonal agent, which could be a respiratory fluoroquinolone, or maybe a gentamicin, any of the anti-pseudomonal agents. So you add it to your piperazine tazobactam. Then, if the person is not critically ill and the person is in shock, or the person requires to be on ventilator, there's a high chance that the person is going to get infection from MRSA. So you have to add something to take care of MRSA, which is going to be your linezolid or your vancomycin. Do you understand this?
Okay, so group 2 and 3 are the same with treatment.
No, group 2 and 3 are not the same. What is group 2?
No, sorry. The greater than 65 age with comorbidity.
Yeah. And you are treating
And
outpatient, right?
yeah, greater than 65 with comorbidities.
Okay,
Is
I'm
it
listening.
Yeah, so greater than 65 with comorbidities and patients with community-acquired requiring hospitalization is the same treatment. It's beta-lactam, macrolide, or respiratory fluoroquinolone.
That's correct.
Okay.
So if the person requires ICU, what do you do? Outpatient.
You
Outpatient coming from community, admitting straight to ICU. What do you give?
beta-lactam macrolide or beta-lactam fluoroquinolone.
Good. If the person develops in the hospital and the person has immunodeficiency or structural lung disease, what do you give?
You add anti-pseudomonas.
Yeah. So you start with an anti-pseudomonas. That's what you are going to give majorly until you now do your culture. Do you understand? In that kind of person, because
Yes.
the most common cause of pneumonia in that kind of person will be pseudomonas. So what you do is that you empirically start with pseudomonas. True pseudomonas, because the person has structural lung disease or immunodeficiency. So you start with true pseudomonas. Then you now do your culture. Anything you now grow, you now change it to that. Do you get? But if the person is coming with shock or the person requires ventilation in the hospital, then you have to add anti-MRSA to your 2 anti-pseudomonal agents.
Okay.
So that's going to be your piperazine tazobactam with gentamicin or piperazine tazobactam with levofloxacin with linezolid or vancomycin. Just say all these things to yourself. Tell it to people. That's how you can stay. There's no magic. It's a lot of algorithm, but you have to know it, and you can only know it when you try to teach people or you try to learn it by heart, right? So I've talked about the pneumococcal vaccine. You give it to all children less than 5 years or people more than 65 years. Those are the 2 categories. Either a child is less than 65, less than 5, or the person is an adult is more than 65. You give them pseudomonal anti-pneumococcal vaccine. And anybody with other comorbidity, lung disease, heart disease, liver disease, kidney issues, diabetes, smoker, asplenia, immunocompromised, asplenia, CSF leak from trauma, cochlear implants, they have to take pneumococcal vaccine. So just start with the age. Less than 5, you have to take. More than 65, you have to take. Are you having any chronic illness? Lung, liver, kidney, heart, you have to take. Are you diabetic? You have to take. Are you a smoker? You have to take. Are you having asplenia? Because this is encapsulated organism. You have to take. Are you having any CSF leak? You have to take, because there's high risk of meningitis from this guy. Cochlear implant, they can develop meningitis from pneumococcal. So you have to give them. You can say that, you can say it. There are stuff that are. By the time you become conversant with these things, if you see it in question, it will come to you fast. So, what about influenza? Influenza is also cause of atypical pneumonia, and we already know the 2 glycoproteins it has, the hemagglutinin and the neuraminidase. We know that, and we have the 2 phenomenon, the antigenic drift and the antigenic shift. The one that is more severe is the antigenic shift. Severe S, shift S, more severe. So the drift just means that as the influenza is replicating, right, there's a minute or a small changes in the neuraminidase and the hemagglutinin it's producing. So there are some accumulated point mutation. So it can cause like a local, epidemics, right? in which you just see that some certain group of people cannot achieve immunity. Like their immunity cannot protect them against the new um, influenza virus that is replicated. So that's just going to cause like a small epidemic. But in a case of antigenic shift, the problem is not due to point mutation from the replication. No, the problem is that you have two influenza virus. For example, influenza virus in probably from, okay, don't let me say, just let me say that two subtype of influenza virus infect a common host, and in the process of infecting that common host, they interchange their genetic material through the process of genetic reassortment. That influenza virus that you are going to release is going to be a new one. For example, if serotype A is the one that can infect human and serotype B is the one that can infect pig, if both of them infect a common host, they are going to produce probably a new, entirely different influenza virus that the world has never seen before. So what do you think that is going to cause? Anybody? The world has not seen it before. What is it going to cause?
Pandemic.
Pandemic. So you can say that it's very simple. You don't need to overthink it. Just look at shift, severe. That's the most severe one. Now, what is causing the drift one? Point mutation. You know that the influenza virus will replicate now, and as they are replicating, there's going to be some genetic errors, and these errors are going to be accumulating, and you just notice that it's producing differences with some little changes in the neuraminidase, little changes in the hemagglutinin that the immunity cannot recognize, and they are going to be causing problems. But it's not very severe. But for the shift, you are changing the entire genome entirely. The entire genome is changing, and the world has not seen it before, so it's going to lead to pandemics. Don't forget the concept behind them. You can test them. How do you vaccinate against what's it called, influenza? It's annual, right? And you start the vaccination in children more than 6 months, unlike in strep pneumo, less than 5 years. Here, they have to be more than 6 months to whatever years, but at least they have to be 6 months. Now, there's a catch. You give two types. There are two types: the intranasal and the high M. The high M is the one that is inactivated, why the intranasal one is the live one, the live attenuated. So that means that if the person is pregnant or the person has HIV, CD4 count less than 200, you cannot give the intranasal form of influenza. You have to know this because they are going to put both formulation in the question. So you must know which one you are not going to give. Intranasal is the one that is live. The high M one is the one that is killed. So it's better to give the killed one, right? And that's the first thing to know. The second thing to know is that most of the time you just give it once annually. But in a child that is between the age of 6 months to 8 years, they must take it twice. They must take it twice in a year. So meaning that they'll take the first one now, and you allow at least 4 weeks apart, you give the second one. That's going to take them for that year. But if the person is 9 years above, you don't need to worry about giving second dose. Just be giving them one dose. That is it. And in another category of people that are more than 65 years, or people that are immunocompromised, they are high risk for developing influenza vaccine, for developing influenza infection. So you must give them high dose killed vaccine at age of 65 above or immunocompromised state. So there are so many vaccines you must not forget for the immunocompromised state. Influenza is one of them. Strep pneumo is another. Very, very important. You also have to give strep pneumo vaccine in individuals more than 65 as well. You can see that all these algorithms are not too hard. I know that once this individual is immunocompromised more than 65, I have to give influenza and strep pneumo. So, somebody wants to ask a question.
Sorry, Chief, I have a question.
Yes.
So which set of people are using the intranasal influenza vaccine?
The intranasal influenza vaccine is not frequently being used. Do you get? It's not frequently being used again. The intramuscular one is the one that you tend to give, right? But if you don't have the IM one, you can still give the intranasal one, but just make sure that that person is immunocompetent. Do you get it? But the preferred one is to give the IM one that is safe. But if the person is immunocompetent and you have the intranasal one, you can give them. Okay, so that's the way it works. Hello?
Okay.
Yeah.
I think that was what I wanted to ask.
Yeah, so that's just a catch. It's just a catch. It's the catch that they will put there. Immunocompromised, immunosuppressed, um, just something that will be HIV, just watch out for all those things so that you don't make the mistake. So, how's the history going to be like? The fever, the malaria, the chills, the coryza, the weakness, the headaches. You can see that all these things are not what you expect in typical pneumonia. They will tell you the cough is dry. So somebody having chills, malaria, coryza, runny nose, that's viral. So think about influenza in that person. So it's a clinical diagnosis, but you can do a rapid test to make your diagnosis. And sometimes you might need to do a viral culture or PCR. That is not going to be tested. Just know that it is a viral diagnosis. It is a clinical diagnosis. So leukopenia is a common finding at the early stage, but later you would start having leukocytosis. How do you treat them? Symptomatic treatment, just supportive. Hydrate them. They can have sore throat, all those things. So hydrate them. Give them analgesics if you're having sore throat, you're having pain. The analgesics can also work for the fever. And if you catch them within 2 days of presentation, you can add your oseltamivir or your zanamivir, which are your neuraminidase inhibitor, so that you can shorten duration of the infection by at least 1 to 3 days, right? Although it's going to be self-resolving, you don't want the patient to suffer, so you can give your oseltamivir and your zanamivir. But once it's more than 2 days, it has no use. So watch out for the complication. They can develop ARDS in people that are immunosuppressed. They can have secondary bacterial pneumonia like superimposed Staph aureus, superimposed strep pneumo. They can develop sinusitis, bronchitis, and exacerbation of COPD and asthma. So part of the cause of exacerbation is what? Infection, like influenza. So let me see. I don't have any question. So let's go to the aspergillosis. I think maybe by 2:30 we're going to take a break. So let me just see if we can finish this aspergillosis. Yeah. So aspergillosis is already what we know. How do you identify it? You are going to see branching, 45-degree branching with septate hyphae. So once you see septate hyphae, 45-degree branching, think about aspergillosis. Septate hyphae, 45 degrees. We have different extremes, different forms of the infection. The allergic bronchopulmonary aspergillosis. So that's the first one, and we know this very well. I've discussed it. It is a hypersensitivity reaction to aspergillus spore in people with asthma or cystic fibrosis. So most of the time, you're going to see either of these in the question stem, and they'll tell you that the person is presented with cough, chest pain, wheezing, that's not responding to antibiotics. Think about allergic bronchopulmonary aspergillosis. They did the lab, they are saying that the eosinophil count is more than 500. They did the sputum, the eosinophils count is more than what? Anybody remembers? If they do the sputum, what do you expect?
25.
More than
300
25%.
with 25,
More
yeah.
than 25%. So, this is likely going to be an allergic eosinophilic problem. So, if you order your chest X-ray, what are you going to see? You are going to see a mass, within a cavity, something like this, something that looks like okay, no, this is not. Yeah, you can have like aspergillus ball within a cavity, something similar to this. But if you do a lab test, it can be normal. Aside all those things that we have talked about, the IgE, what's it called, your skin prick test, which is going to show positive to this aspergillus. You measure your IgE against your aspergillus, is going to be positive to yeah, I think those are the stuff. Then you can do your total precipitin count, in which you are going to see that your IgM, your IgE towards this aspergillus is going to be elevated. So most of the time you don't give antifungal because they are not going to be effective. So what you have to do is to go in and remove it. If the individual is symptomatic, you go in and remove that fungal ball by surgical resection. And if the person is already present with hemoptysis, you have to do a bronchial embolization to stop the hemoptysis. We are going to talk about hemoptysis very shortly, and we are going to look through the potential causes. So don't forget, these individuals, oh my God, I'm talking about another thing entirely. Okay, so let me take it again. Just sorry about that. I have mixed
I'm
it up.
talking about aspergilloma.
Yeah, I've mixed it up. So the one we are talking about initially is the allergic bronchopulmonary aspergillosis, and we have said that they are going to be having asthma and cystic fibrosis, and they are going to be having like asthma-like symptoms, and they are not going to be responsive to antibiotics. If you do your skin prick test, you are going to be seeing positivity towards aspergillus organism. If you measure your IgE against the aspergillus, is going to be positive. And your mainstay of treatment for your allergic bronchopulmonary aspergillosis is to give your antifungal like a voriconazole, itraconazole. You had your steroids to eat. Those are the two major mainstay of treatment. And if the asthma is very bad, you have to give omalizumab, your anti-IgE, to take care of it. Omalizumab also works in people with cystic fibrosis having ABPA. Yeah. So that is that about as per ABPA, and the labs is going to be showing us what? Elevated IgE, elevated eosinophil counts, and the likes. Then the next is the aspergilloma. So that's the one I was saying that was confusing. Yeah. So sorry about that. And what you typically have in aspergilloma is just like a ball of fungus settling in a cavity. That's just it. You have like a cavity, maybe the person has COPD or the person has tuberculosis, and you have aspergilloma ball mold settling within that cavity. Most of the time, it will be asymptomatic, but sometimes they can have rupturing of that cavity, making them present with hemoptysis. So most of the time, you will not see any systemic symptoms like fever or cough. They will not have. They'll be asymptomatic. In fact, it is an incidental finding. If you do your X-ray, you're just going to see like something looking like this, like a ball of fungus in the X-ray, right? That is aspergilloma. No fever, no cough, nothing. So the labs will be normal. You will not see anything. They are very quiescent. You don't have to give any antifungal. They will not work because they are in the cavity. Or like in ABPA, that you have to give your itraconazole, your voriconazole, and your steroids. Here, you don't give any antifungal. You just go and remove that ball. If the individual is symptomatic, that is, if the person starts presenting with hemoptysis, serious cough, you now have to go in and do a surgical evacuation of that cavity and the fungal ball. And if the person is bleeding badly, you have to do a bronchial embolization to stop the hemoptysis. That is about aspergilloma. Now, another thing that I must mention about aspergilloma is that the question can tell you that when they did the CT or the X-ray and they tell the person to change with position, the mass is also moving. Very high yield. Very, very high yield. So you are going to see a mass that moves with change in position. And of course, you are going to see the hair crescent sign. So hair crescent sign is just an area of hyperlucency surrounding that cavity. You can see this. This is hair. Can you see this? Can we say that this looks like crescent? What is another name for crescent?
Moon shaped, is it?
Yeah, moon shape. So you can see that this looks like half of a moon. So this is the hair crescent sign, which is classic for aspergilloma, and the mass will move with changing posture. Aspergilloma. Now, chronic necrotizing pulmonary aspergillosis is just like aspergilloma, but the symptomatic form. That's the way to put it. So, because aspergilloma, they don't have any symptom, but in chronic necrotizing pulmonary aspergillosis, they can present with symptoms. And it's very common in people with immunosuppression from anything. You don't need to cram anything. Just know that there's going to be immunosuppression. And what is a triad you are looking out for? By the time you do your imaging, you are seeing a cavity like this, containing maybe aspergilloma, debris, fluid, and the person is having some symptoms for like 3 months, like cough, like weight loss majorly, because this is a chronic problem. weight loss, the cough, the hemoptysis, whatever they're having, or the drenching eye sweat, fatigue for at least 3 months. And the third trial is um, serology, which is IgG towards aspergillosis as positive. So I think I have it here. Yeah. So 3 months of symptoms: fever, weight loss, fatigue, hemoptysis, cavitary lesions that contains debris, fluid, or aspergilloma, and a positive aspergillus IgG serology. Once you have these three, you are dealing with a chronic pulmonary aspergillosis. Now, what will now make it necrotizing is that in your X-ray, you're also going to be seeing features of necrosis, cavities, in the lung. So you can say this is chronic necrotizing pulmonary aspergillosis. Please, do we understand this? Hello, no response.
Kind of.
Yeah. What was the? You said you mentioned the triad or something.
Yeah. I said number one, that individual is going to be having
The
symptoms
3
for at
months.
least 3 months. Do they have symptoms in aspergilloma?
Okay.
Do they have symptoms in
No.
aspergilloma? No.
No.
So there's no systemic symptom, no fever, no chills, nothing, no cough, nothing. So if you are seeing symptoms, you are not thinking of aspergilloma first. Then you look at the cavity, the X-ray finding. You are seeing your ball of fungus within the cavity with areas of necrosis. Which can contain fluid, it can contain debris. That's number two. Number three is now when you do your lab test. They said lab test is negative in aspergilloma, but you do your lab test, you are seeing serology, positive IgG towards aspergillus. Are you still going to be thinking aspergilloma?
No.
No. So that is chronic necrotizing pulmonary aspergillosis. Very easy. Then the last is now your invasive pulmonary aspergillosis. Now, the difference between this and this is that this one, the progression is rapidly. The progression is rapid. It's also common in immunosuppressed people, and they will tell you that the infection is disseminating to other parts, the joints, septic dissemination to the joint, to the brain, to the liver, different part of the body. And the individual is going to be having the symptoms, the fever, the cough, the chest pain, anything. Just think about anything. But your lab work will also guide you to think about invasive pulmonary aspergillosis. Apart from the fact that it is disseminating, it is rapidly progressive. If you do your serum galactomannan assay, it's going to be positive. If you do your serum beta-glucan assay, it is going to be positive. If you do your IgG serology too, it's going to be positive. But if you don't have all this and you are still thinking of invasive pulmonary aspergillosis, you can now do your bronchoalveolar lavage to culture whatever you have there. Or you do your biopsy and you're going to be seeing what on biopsy. Anybody knows what you are going to be seeing?
Galactomannan.
No, on biopsy.
Hello.
Eh?
The hello.
The what?
The hello.
What's the hello?
All those with hello sign.
No, Dr. Antonia, you are biopsying. Hello sign is your sign on imaging, right?
Mm-hmm.
If you biopsy a tissue that contains aspergillosis, what do you expect to find?
Is it the septate hyphae?
Yes, there's no catch. You are going to see the organism, which is what? Because when you biopsy, you stain. What do you do after you biopsy a lesion? You stain it. Then you are going to see the septic hyphae branching at 45 degrees. No catch. There's no catch at all. So, which corresponds to the aspergillus organism. Then, for the chronic necrotizing, just give your drugs. And if the person is having hemoptysis, do a surgical resection. It's only in aspergilloma that your drugs do not work. For your invasive pulmonary aspergillosis, to give your drugs, your voriconazole with your chinocantine, and you treat the underlying cause of the, immunosuppression. So I hope we can say one or two things if we ask to differentiate between invasive pulmonary aspergillosis and necrotizing pulmonary aspergillosis. Can we?
Yes.
Okay.
They give us lab findings.
Yeah, they will give you the lab findings.
Have symptoms and everything.
Let's see one or two questions. So, answer is already here. So, a 54-year-old man comes to the office due to fatigue, productive cough, blood tinged sputum, weight loss over the past few months. He has no fever, no chest pain, no sweat. 10 years ago, he emigrated from Victor and he has received treatment for pulmonary TB. No other medical history is positive. Does not use tobacco, does not use drugs. He drinks alcohol occasionally. Temperature is normal. Blood pressure is okay. Pulse is okay. There is a right-sided ronca and crackles on lung auscultation. Creatinine is okay. The noise is normal. CT scan shows the image below. Okay, I think I'm supposed to even show us image of the halo sign Dr. Antonia mentioned. Probably I have it deleted. So in invasive pulmonary aspergillosis, you have the halo sign in which you are going to be seeing the nodule with surrounding area of ground glass opacity. So let me see halo sign of invasive before we go to that question. Yeah, so once you see this, so don't think this is like cavity. So you can see that this is showing like a nodule with an area of fluffiness, ground glass opacity. So that's classic for invasive aspergillosis. But I don't think I even have the image of there. When you try to sort all these questions at times, you can, and you don't remember to save whatever you have uploaded, and okay, I think I have the image here. I have it. Okay, so what is this going to be? Wait, before I ask you, let me calm down and do this. Okay, just you word. Okay, I think this is the image. So, what do we think this is? Anybody? There's no catch.
Like aspergilloma.
Okay, so it can be either aspergilloma or chronic
necrotizing. Chronic necrotizing because of the air crescent.
Yeah, because both of them will have the cavity with the air crescent. Good, I agree with you. Now let's now go back to the question to now know which one is it. A 54-year-old man having fatigue, productive cough, productive pressure, blah blah blah. So which one do you think it is now?
No symptoms, so aspergilloma.
Chronic
Why is it?
aspergillosis. Chronic
Why are you
pulmonary aspergillosis.
Why are you saying there's no symptom? Is fatigue, cough, hemoptysis
There's
not a symptom?
symptom.
Weight
Okay.
loss.
Yeah. Okay, weight loss. Yeah.
That's a symptom.
So
Chronic pulmonary aspergillosis.
So chronic pulmonary aspergillosis is going to be the answer. If they put invasive here, please don't pick invasive because that's not the halo sign. So this is chronic pulmonary. So that's how you are going to be looking at it. Also, is here a symptom, systemic symptoms, not only hemoptysis. Are you seeing fever, cough? You pick chronic pulmonary and weight loss, chronic pulmonary aspergillosis. If you are just seeing, no symptomatic, blah blah, you can think more of aspergilloma. The pity I have only one question there. And how do you want to treat that patient?
Voriconazole.
Voriconazole. And because this person is having hemoptysis now, you can do what?
surgical
resection. Surgical resection.
Okay. Once we have that at the back of our mind, I'm sure we can tackle any question. I can assure you.
Is it fluconazole or voriconazole?
Don't pick fluconazole, please.
That's what I'm saying. I heard fluconazole.
No, she said voriconazole. She didn't say fluconazole. So
I just want to be sure.
Voriconazole. Or itraconazole. Any one of them. So, let's just try and finish this infection before we go for our break. So should we go for a break now? Because I don't want people to be too tired. What do we think?
Sorry, Chief, one more thing. This air crescent sign that you see, you see it both in aspergilloma and pulmonary aspergillosis?
Yes, because it's indicative of a chronic aspergilloma. Do you get it, Dr. Mary?
Okay.
So
Yeah,
you see it
thank
in
you.
both of them. But it is a symptom that will help you to differentiate
Yeah,
between them.
differentiate.
Yeah. Okay, but let's continue. So let's just do histoplasmosis and we stop. So histoplasmosis, we know, I've said it, one thing I said about it. Make sure that the patient, if you see somebody having symptoms of histoplasmosis, rule out what? Rule out, anybody remembers?
HIV,
Pneumonia.
HIV,
Pneumonia.
immunosuppression.
Yes, rule out immunosuppression. People
Okay,
with
okay.
histoplasmosis don't have symptoms usually. But once there's any cause of immunosuppression, that's when they now see them having pneumonia. So these factors include HIV, people that go and explore caves, because in these caves you have the dungs of the birds and the bats. So by the time they start exploring the caves, they can get exposed to the dungs and birds, the the, the dungs of the bird and the bats, and from there they can develop the histoplasmosis. And the location is classic, for people that do all these things in the Ohio and the Mississippi area. Very important. Just like blastomycosis. So blastomycosis and histoplasmosis, both of them, Ohio and Mississippi predominant. So most of the time, primary exposure is asymptomatic. They don't have anything, or they can just have flu-like illness. But if they have a background immunosuppression, you can have some symptoms. Now, they can have almost anything, but the ones you must never forget is what? The pneumonia-like presentation, which includes fever, cough. Do you expect this cough to be productive or not? Anybody? Nobody's saying anything. There's no catch.
Non-productive.
Non-productive. This is not a typical cause of pneumonia, so it will not be productive. So non-productive cough, fever, they are going to be having dissemination to other organs like the liver, like the spleen, lymph nodes. So there's going to be lymphadenopathy, there's going to be hepatosplenomegaly, and it can go to the bone marrow, pancytopenia. Then one thing about it is not to forget the horse, hepatosplenomegaly, the oropharyngeal ulcers, the rash, erythema what?
Erythema
Noodles.
nodosum
Erythema
multiforme.
nodosum, the splenomegaly, and the erythema nodosum. So don't forget, and it can disseminate to the bone marrow, causing pancytopenia. So think about the lungs, think about the liver, think about the spleen, think about the lymph nodes, think about the mouth, think about the bone marrow. Those are the places histoplasmosis can go to. Hepatosplenomegaly, lymphadenopathy, non-productive, disseminated cause. Now, how do you want to make your diagnosis? You can do an initial X-ray, and you are going to be seeing diffuse nodular density. So either you are seeing nodules, cavities, infiltrates, or just highlight lymphadenopathy. So cavities, particularly for the chronic ones, infiltrate, nodular densities, those are the things you are going to be seeing. But the gold standard to make it diagnosis is like the most sensitive, don't let me say gold standard, the most sensitive is to do your urine and the serum polysaccharide antigen test. This is what you are going to be seeing in the question most of the time. Your urine is just like Legionella. This one too, urine or serum polysaccharide antigen test. Do not forget for histoplasmosis. Urine and serum polysaccharide antigen. You want to pick that antigen in the urine or the serum. Now, if you do your biopsy and you are doing your staining, what are you going to see? Don't forget, in our microbiology section, we said you are going to be seeing your yeast of the histoplasmosis, infiltrating into the macrophage. So this is a macrophage with the tiny, tiny yeast surrounding it. And the size of the yeast is going to be compared with the neighboring red blood cells, and they are going to look smaller. So the yeast are smaller than the red blood cell. And another thing that the question might add to the yeast shape is what they call narrow body. It is not only Cryptococcus neoformans that have narrow body. Histoplasmosis can also have narrow body. Their yeast is going to be smaller than the red blood cell and is going to be infiltrating into the macrophages. How do you treat? Now, what you have to have at the back of your mind is that all this chronic fungal infection, once you are able to elicit a very severe acute infection or a disseminated infection, you give an induction dose of liposomal IV amphotericin B. for 14 days. Then you now continue with your itraconazole for 1 year or more. Very, very important. Once you are saying that this infection is bad acutely, or it is disseminated, it's already affecting the lymph node, the bone marrow, the liver, the spleen, disseminated infection, start with IV amphotericin B and continue with your itraconazole. Good. If all what you are just seeing is just nodules, the person is not symptomatic, just nodules or mild presentation, you just ask yourself, is this person immunocompetent or not? You already know that the problem in histoplasmosis is that most of the time they are immunosuppressed, and that's when they start having all these problems. So if the patient is immunosuppressed, and the person having mild or nodular presentation, give itraconazole. But if the person is immunocompetent and is having stable nodules, mild presentation, do not give anything. Just give supportive treatment. Maybe the person having pain, antipyretics or something. Just support it. Do not give itraconazole. But if you are seeing chronic cavitary lesions, there's a high chance of reactivation. There's a chance of hemorrhage. So you want to keep that infection in check. So you have to give them itraconazole for at least 1 year. You see, for the other ones, the only one that will be changing will be the chronic presentation, right? But the acute and disseminated will always remain the same. Once it is acute and disseminated, give your liposomal amphotericin B and continue with your itraconazole, right? So let us take a break. I think we are done. Yeah. So go to the next one. Let's take a break now. I will come back in like is 43. Come back in 3 o'clock. Is that okay?
Yeah.
Yes.
Okay. All right.
Yes.
Hello. Hello everyone. Are we still there? Hello. Okay. So sorry about that. Yeah. So don't forget about the approach to treat the histoplasmosis. If the pulmonary disease just mild, they're having stable nodules, and the patient is immunocompetent, don't do anything. Just treat supportively. But if the person is immunosuppressed, even despite the stable nodules and the mild pulmonary disease, still give itraconazole. For the chronic cavitary, give itraconazole for 1 year. For the acute pulmonary disease that's severe or disseminated, give your amphotericin and continue with your itraconazole. Now, for the coccidioidomycosis, this is endemic to the southwestern US, like the California, the Colorado that you have said. We have to be familiar with some of those states. And just like histoplasmosis too, they will have the pneumonia-like features like fever, cough, chest pain, lymphadenopathy and the like. But what is more specific for coccidioidomycosis that you must not forget is the fact that it can affect the skin, the joints, the bone, and the brain. So you cannot forget that. So the brain, it's a common cause of meningitis. The bone, they can cause osteolytic bone lesions, cause bone pain in the ribs, the vertebrae. They can affect the skin and cause erythema multiforme and erythema nodosum. Both of them. So that we call that desert bumps, desert bumps and desert rheumatism. So they can cause erythema nodosum, erythema multiforme, and for the joint, they can cause joint pain, arthralgia. So desert rheumatism, desert bumps. So the desert bumps is the erythema nodosum or the multiforme. The desert rheumatism is the arthralgia that they experience. So it can affect the joints, the bone, the skin, the CNS, meningitis. Very, very important. Very, very important. And people with HIV are very predisposed to developing severe form. People that are pregnant, people that have African or Filipino descent. We don't actually need this information. It's not going to be tested. But if they are going to test anything, it's going to be tied to maybe HIV or pregnancy. Nobody expects you to be cramming Filipino or African. But if you want to know it, it's good to know it, but you might forget it. So the predisposing factor is same as histoplasmosis. People that undergo the cave exploration or earthquakes, they can inhale the dust containing the spores and they can develop the coccidioidomycosis. Just like I've said, the constitutional symptoms of the pneumonia, the cough, the chest pain, the headache, arthralgia, disseminated infection to the bone lesions to the brain, meningitis to the soft tissue, they can have access to. One thing about the coccidioidomycosis is that diagnosis, if you rely on serology in the first 2 weeks, it's only the IgM that will be there. After the first 2 weeks, you only see the IgM. Then about a month it disappears. Then your IgG will now start appearing. So within the first 2 weeks, you might not get anything. So the best approach is just to do your PCR. So what's the best approach to make diagnosis of histoplasmosis? Anybody?
Urine serum polysaccharide antigen detection.
Fantastic. So this one, you do your PCR. Don't forget, you do your PCR. So PCR, coccidioidomycosis, PCR. And if you do your histology, you are just going to be seeing the spherules with the endospore, right? Don't forget, we remember all these things are basic microbiology stuff that we know, spinal level. So spherules with the endospore, coccidioidomycosis. Yeah. So the management is another thing I need to emphasize. So categorize into the acute and the chronic. Now, for the acute, what did we say we are going to be using for acute severe for histoplasmosis? Acute severe form of
IV
histoplasmosis. Huh?
IV amphotericin B.
Exactly. Yeah, the same thing works here. So acute severe, you give your IV amphotericin B, and followed by your azole, your itraconazole stable. Same thing also works here. And acute severe or disseminated, the same approach. IV amphotericin B and your azole. Now, the only difference is that that in the chronic form of histoplasmosis, we said that histoplasmosis has a very high chance of transformating into the more severe blah blah blah. The chronic one can rupture hemoptysis and the like, so you might want to give itraconazole. But the chronic one for coccidioidomycosis, just look at it as okay. The chronic form is much more stable. So even if the person is asymptomatic and just having the cavities only, don't do anything. You only give drugs, which is your itraconazole and surgery. You remove the cavities only if the cavities are enlarging progressively or the person is symptomatic. Do you understand that distinction? You see, once you get that distinction, you can never forget the treatment again. Do you understand that?
Please come again.
Yes.
Okay. I said the chronic cavitary form of histoplasmosis, you will give itraconazole, right? Now, the chronic form of your coccidioidomycosis, you don't give anything. The only thing that can make you do surgery to remove the cavities or to and add drug to the cavity, to the surgery, is if that cavity is enlarging or the person is symptomatic. The cavity is enlarging, the person is not symptomatic. The person is symptomatic. Once the person shall have chronic cavitary lesion in histoplasmosis, you have to give drugs. But in coccidioidomycosis, the chronic form, once it's stable, do nothing. If it is progressive, if the person is symptomatic, you have to do surgery and give your azole. Don't forget, you have to do surgery to remove the cavity. Okay? Do you get that, Dr. Miriam? So,
Yes, thank you.
so if the person is having acute form, not severe, you can give just mild. You can give your fluconazole or itraconazole. But if it's severe, IV amphotericin B and your azole. If it's disseminated, IV amphotericin B and azole. Once you have this at the back of your mind, you are okay. The same thing also works for blastomycosis. Severe form, severe acute disseminated form, admit to ICU, IV and amphotericin B, and your what? Azole. If the patient is not having the disseminated form, just mild acute, you can give your itraconazole. That's the way it works. Very easy. So, what about plastomycosis that you should not forget? Number one, plastomycosis, just like histomycosis, both of them, they stay just like histoplasmosis. They affect people in Mississippi and the Ohio. That's number 1 point. Number 2 point is that this presents just like pneumonia, the fever, chest pain, the dry cough, the difficulty in breathing. And in addition to that, you're going to see um, urogenital problems. So they are the one specifically that affect the urogenital tract. So they can have prostatitis, they can have epididymal orchitis, epididymal orchitis, prostatitis. Think about blastomycosis. That is not enough. We are looking for more. Lesions in the skin. They are not going to be presented with erythema nodosum or multiforme that like coccidioidomycosis. That's only joking. This one will blast that skin, and you're going to be seeing verrucous, warty lesion. So if you are thinking of a fungal infection, you are seeing verrucous, wart-like lesion, like someone that has squamous cell cancer of the skin, that is blastomycosis you are dealing with. Very easy. The bone lesion, they can cause osteolytic bone lesion too, just like coccidioidomycosis. You are going to see rib pain, vertebral pain, pain, long bones, femur, and the likes, right? And when you do your culture, now the gold standard to diagnose this one is culture. The best to diagnose your coccidioidomycosis is what?
Sorry, you said what?
The best to diagnose your coccidioidomycosis that we said is what?
PCR.
PCR. The best to diagnose your histoplasmosis is what?
Serum urine
You
polysaccharide
see.
antigen.
Then the blastomycosis is what? Your culture. And what do you see when you do your culture? You see your blastomycosis hyphae or the yeast, but they are going to be appearing with broad-based body, right? Very easy. Broad-based body. Don't forget infection of your urogenital tract, prostatitis, epididymal orchitis, the skin. You're going to be seeing what? Verrucous, warty lesion. In fact, it's going to look as if that person has had like almost marginal ulcer of the leg. It's going to be very bad, blastomycosis. So once you see that in question, you already know what you are dealing with. So it's very easy. So, oh, no. Let's see, legs. Something like this, non-kneeling, something like this, what-like stuff. Although these ones are not very classical, there's one that is in first aid that you need to that we need to check. I think we need to check the one in first aid. All these ones are still like mild. The one they have in that first aid is very bad. And just be rest assured, the question is going to describe the lesion, so you will know what you are dealing with. So don't forget, severe acute infection or disseminated infection. What do we do? Hello?
Hello, for which one?
Any one of them.
IV and Amphotericin B,
IV
severe one.
V, and you continue your itraconazole.
Itraconazole.
But for the mild acute, what do you do? Your
Oral fluconazole or itraconazole.
Exactly. So can go to the brain, can go to anywhere. Once you see dissemination, just give your IV amphotericin B ion. Let's see if we have some questions. Just substantiate things. So, a 30-year-old woman comes to the physician because of dry cough, chest discomfort for the past 3 days. During this period, the parent had headaches, muscle ache, and pain, fever, tubes. 10 days ago, she was hiking with her family in Mississippi. So, with Mississippi, what are the two differentials?
Histo and blasto.
Histo and blasto. Patient had asthma and is treated with albuterol. The mother had lung disease, treated with methotrexate. Patient has smoked 1 pack of cigarette daily for the past 10 years. Temperature is elevated. Wheezing in both lung leaves. Analysis is positive for polysaccharide antigen. Spot diagnosis. What's our answer? Spot diagnosis. We don't need to finish it.
Histoplasmosis.
Histoplasmosis. So they told us that they were seeing macrophages filled with other cells that measure 1 to 5 millimeter, and the body has a narrow base, which is still in keeping with histoplasmosis. They are involved in the macrophages, histoplasmosis. The seborrheic agar is the fungal agar. So you can use it to grow any of the fungus. Septic typhoid, very easy stuff. A 35-year-old military nurse with Crohn's disease comes to the physician because of 3-week history of fatigue, fever, dry cough, headache, malaria. In this period, he has also had 4 kg weight loss. 1 week ago, he developed several painful oral lesions and difficulty swallowing. We already have something in our mind, right? Abi now? So we are not answering. Oral lesions. Already
Sorry,
having
reading
something.
the
Hmm?
yeah answer.
Okay. He serves in a military base in Ohio. I mean, they have
Histo.
histoplasmosis. So now your job is just to finish. And you know what I'm doing. I'm not encouraging us to be making our answer halfway. What I'm
Mm-hmm.
just saying is you have something in your mind, then you just read through and consolidate your answer with whatever is down. That's just it. That's just your job. Please always make sure you finish the question. Make sure you finish the question. Temperature is 38. Vitals okay. Physical examination shows diffuse bilateral calculus, hepatosplenomegaly. You see, multiple 1 to 2 centimeter ulcerative lesion will raise border and oral mucosa. Lab shows this liver pathology. Result of combined HIV antibody and interferon gamma is negative. Now, what do you think is the predisposing lesion to this presentation? Anybody? We are not talking.
Chief, I
Yeah,
didn't
well,
get the question.
this what
Like,
but the HIV antibody is negative and the
what is the
TB
predisposing? What is
Treatment
predisposing
of
the person to develop?
is
Eh?
in
A what?
military base.
Eh?
Military base. He serves at a military base in Ohio.
Okay, the location, but he might have it from this location and still be asymptomatic. So what is making the person symptomatic?
Prednisone. He's on prednisone
He's
and
on
infliximab.
prednisone. The guy is on prednisone and infliximab. So they are trying to tell us that it's not HIV. So that's why they are telling us, because they are also thinking like a normal physician should do, rule out HIV. And the interferon gamma was negative. X-ray of the chest shows hilar and venopathy with central ganglion, blah blah blah. Nodules. You can see the nodules. Nodules. So either you are seeing nodules, which can be stable. If they are stable and the person is immunocompromised, you give itraconazole. If they are stable and the person is immunocompetent, do nothing. So, an X-ray of the shows hilar lymphadenopathy with the central calcification and multiple well-defined pulmonary nodules measuring this. Which of the following is the most appropriate treatment? Now, what are you going to give this individual? Please don't follow my answer. Go with your own understanding of the topic and pick your answer.
This person is immunosuppressed and is symptomatic. So I will treat.
Mm-hmm.
I'll
So,
give amphotericin B.
yeah. So why are you giving amphotericin B?
It's an acute symptom.
Okay,
It's an
aside
acute
that,
symptom
aside that,
and the patient is also immunosuppressed.
but there's something more pressing than that. Aside that,
Mm, weight loss.
no. Like, what are the two conditions that will make you give amphotericin B? Just ask yourself, what are the two conditions that
If
will make
it's
you give?
severe, if it's acute, severe, and disseminating.
Yeah. So, do you think this person meets the true criteria?
Yes.
Yes. So why is this person having disseminated form?
The immunosuppression now helped in disseminating it.
No, Dr. Antonia, like you have to be objective. Like somebody can have immunosuppression and not have disseminated presentation, but this person is having disseminated presentation because of some things we are seeing. What are we seeing?
Crohn's disease.
Hmm?
Is it because of the Crohn's disease?
Hepatosplenomegaly
There's
disease.
hepatosplenomegaly. There's oral lesion.
Mm-hmm.
I mean, everything is here. So we cannot say that because it's immunosuppressed. No, this person is having hepatosplenomegaly. That's disseminated. Normally, if you're having histoplasmosis, it's just the lungs. Right there, just a flu-like lesion. That's all. But when it starts getting to the mouth, start having hepatosplenomegaly, start having lymph node, it's disseminated. So that is the reason why you're giving amphotericin B. So let's have that at the back of our mind. Very important stuff. Once you are seeing any of the horse, even if it's some simple skin lesion, it is disseminated. Give you amphotericin B. A 50-year-old man comes to the physician because of 4 weeks history of intermittent fever, cough, general breath. 3 weeks ago, he was treated with amoxiclav and azithromycin. Now, what do you guys think they are giving this for? Anybody?
For pneumonia.
For pneumonia. You can see application of what we are learning. What type of pneumonia do you think they are treating with this?
Acquired. Community acquired.
Yeah, community acquired, but Dr. Antonia, put more energy. Like, see, amoxiclav and
Is it?
azithromycin. The what? The what? We are saying something.
Community acquired maybe.
That's acquired with comorbidity or something.
Yes. Probably this person has some
Acquired.
comorbidity. So this is not only going to be normal community acquired on outpatient. No. So it means that if they are giving amoxiclav, which is a beta lactam, which has it true, it means that maybe the person is more than 65 or the person has some comorbidities. Like maybe liver. You see, that's the approach. Now they are giving the drug. The person did not still improve. Now he's also worried because he has been noticing some new bumps on his skin. He's living in upstate New York along the Mohawk River. He has rheumatoid arthritis, of course. He does not smoke. He used metrotrophin and multivitamin. Temperature is elevated. Diffuse crackles are heard over the long field. Skin examination shows multiple white verrucous papules and nodules on the thigh. CT scan shows bilateral tray in board opacities in the lower lobes. A biopsy of the skin nodule shows polygranulomatous inflammation around the cells, which will follow the most likely causal pathogen. Even they are trying to confuse us with things you have not heard before, but there are some things you can pick that we are familiar with. So what are we going for?
Blastomycosis.
Blastomycosis. Very, very easy. Why are you picking blastomycosis?
The varicose skin.
Varicose papules.
It's very simple. So what are you going to give this patient?
Amphotericin B.
No catch. There's no catch. There's already a skin manifestation. It has gone beyond the lungs. Give your amphotericin B and you move. That is it. So that's that about the fungi. Very easy stuff. So going to tuberculosis, we know tuberculosis is affect a lot of people, 2 billion people. We don't need to waste time on the epidemiology. Nobody's going to ask us. We should be familiar with the risk factors. Patient travel history. Where are you coming from? Please, madam, where are you coming from? I'm coming from Thailand. I'm coming from Vietnam. I'm coming from Philippines. I'm coming from Indonesia, Singapore, Cambodia, all these Middle East Asia, Asian countries like that. Nigeria, Sub-Saharan Africa, Ghana, Cameroon. Think about TB. Think about TB. Think about TB. Now, people that are homeless, people that are in incarceration, people in prison, alcohol use, IV drugs, HIV, people that work in healthcare settings like us, people with pre-existing lung disease, people with immunosuppression and advanced age, all of them, they are risk factors for tuberculosis. Most people are infected with TB. Almost everybody have TB, but we are asymptomatic, and that is what we call the latent tuberculosis. Some can have reactivation of that latent TB, and some can develop it primary. The first time they're exposed to that TB, they develop symptoms. That is primary. It's not reactivated or latent. No, it's not reactivation of latent. You are exposed to the TB, bam, and you develop symptoms, bam. That is primary. But if you're exposed to TB, bam, but the immune system keeps it suppressed, and later the immune system weakens and it comes up again. That's secondary. What do you expect? Cough, fever, the weight loss, hemoptysis, night sweat, all those things are classic for tuberculosis. Stretching eye sweat, fatigue, weight loss, right?
It can also affect any other organ, can go to the bone, can go to the brain, TB meningitis, spot disease, TB adrenalitis. We know all these things from our other system that we have covered. Now, what I'm just going to say here is that your tuberculosis skin test is like a test to determine if somebody has been exposed to tuberculosis before or has tuberculosis infection, right? And it can be influenced by somebody that has received a BCG vaccine. So if they ask you, doctor, I have received BCG vaccine, do you think I should do tuberculosis skin test? Don't do tuberculosis skin test for that person because there's going to be a false positivity. What you rather want to do is to do your interferon gamma release assay because the antigen that you are going to be inoculating in doing your interferon gamma release assay is different from the one that was used in the BCG. So your interferon gamma release assay is going to isolate people with BCG vaccination and is not going to include them in the false positive test. But if you do tuberculosis skin test for someone that has BCG vaccine, it's going to be falsely positive. Important stuff. Important stuff. Now, how do you make your diagnosis? Latent disease. You have said it. They have the infection, but they are asymptomatic. They have the infection, or they are asymptomatic. Two ways. Either you do your tuberculosis skin test, or you do your interferon gamma release assay. But if they tell you that this patient has earlier received BCG vaccine, or they tell you that this patient has been previously infected by a non-tuberculous mycobacterial infection, let's say Mycobacterium alternans or Mycobacterium leprae, you are not going to be choosing tuberculosis skin test because you are going to get a false positive test. So in that regard, you are going to be picking interferon gamma release assay to make your diagnosis of latent disease. So what you are just doing for this latent disease is that you are trying to find out, okay, this person does not show signs of TB, but they suspect that this person gets TB. Let me do tests. I can do tuberculosis skin test or interferon gamma release assay. But I don't want tests that will be falsely positive because this person has been previously exposed to leprosy or this person don't receive BCG vaccine. Let me do something else that will give me more reflection. I go for my interferon gamma release assay. Now, how do you read a positive? If you are doing your tuberculosis skin test for an individual that has not been exposed to any other bacterial infection, or the person has not had any BCG vaccine and you want to do tuberculosis skin test, okay, how do you read it to be positive? For you to say that, okay, this person has latent disease. If you put in the antigen to the skin and you see the induration, it is 15 millimeter beyond. That is positive PPD test. And the person is asymptomatic, so you can confidently say that this person has latent disease. Now, you bring the threshold down in people with some conditions. You bring it down in people that live for the sick people in the IDP camp. That's where I put in the acronym. I'm going to bring the threshold down in sick people in IDP camp. Sick, people that have chronic illness, diabetes, malignancy, or in IDP camp, high injection, IV drug abusers, DP camp, people that live in developing countries. Resident of developing countries, Nigeria, Ghana, Cameroon, all this Cambodia and the likes. And people that live in areas where there's a camping, IDP camp, sick, chronic illness, IV drug, developing country for the D, and the people camp, people that live in camps. Are you in a military barrack? Are you in a nursing home, correctional facilities, prisons? This category of people, once I measure my tuberculosis skin test and it is within range of 10 to 14, I say the tuberculosis skin test is positive. The one I'm going to bring it down to 5 to 9 is positive, is when, do you have HIV? Have you been exposed to anybody with tuberculosis? You did the X-ray, you are seeing evidence of tuberculosis. Those category of people. If you do your tuberculosis skin test, it's between 5 to 9. Please, your PPD test is positive in there. You have HIV, you have been exposed to someone with TB, or there's evidence of TB on the chest X-ray, and you're having PPD of 5 to 9. You are positive. sick people in IDP. You have sick chronic illness, IV drug abusers. You are living in developing countries like Nigeria, Cameroon, blah blah blah, or you are living in camps, correctional facilities, prisons, nursing home, and you're having 10 to 14. You are positive. If you are healthy, you are at home, you don't have any problem, and you have 15, you are positive. Now, what is the next thing to do? Before that, you have to know that people that are immunocompromised, they might have a negative TST test. That's why we are bringing the threshold down, because their immune system might be so weakened that they might not be able to mount a rigorous reaction for you to see the induration. So sometimes they can actually have the latent infection, but their TST test will be negative. Please, can we still hear me?
Yes, we're hearing.
Okay. So once you do your PPD test, you are querying latent disease. The next thing for you to do is to do a chest X-ray to rule out active disease, because there are two ways you can know active disease. Either you are showing symptoms, or I do my chest X-ray, I see evidence of TB. If I do my chest X-ray and I see evidence of TB, you have an active disease. So once you have confirmed that this person has active disease, the next thing you want to do is to take a sputum culture. You induce the sputum, you take 3 specimens, because your acid fasting is not sensitive. It is not very, very sensitive. So you have to take 3 different specimens and culture them. Then you now collect specimen for NAT and also for culture. So sorry, I made a mistake. The first sputum you are collecting is to do your staining, your acid fast staining, but it is not sensitive, so you need to take 3. Then after that, you now have to test, the sputum for your NAT as well as for the culture. But you know that culture takes 2 to 3 weeks, so you can't be waiting for culture. So you have to start with your gram stain, progress to your NAT, and your culture. So your NAT is very good because you're able to run it quickly. You identify the gene of your tuberculosis, and you also be able to know the sensitivity to rifampicin. Your culture might take 2-3 weeks, but it's a gold standard. Your culture is a gold standard. Then, of course, you do your acid fast staining. And when you do your acid fast staining, what are you going to see? You are going to see the reddish tuberculosis organism with the background methylene blue counter stain. So the Xenesis stain is red like this, and the background stain, which can be methylene blue or malachite green. So you can see background of green, you can see background of blue, depending on the counter stain that you see, that you use. But the constant one that you see there is the color of the organism, which is going to be red. That's the Xenesis stain. If the person has extrapulmonary TB, you can biopsy the bone and you do the gram staining. You are still going to be seeing the same thing. So don't forget, 3 sputum for your acid fast stain, then obtain other specimen 2 for your NAT and culture if your acid fast stain is positive. That's to confirm your active disease. So
Sorry, Dr. Bobo, can you take that again? You said
so
you take the sputum.
you
Okay,
take
so the algorithm is the skin test or eye graph, just X-ray, then sputum.
yes, kind of,
So in
so
the sputum, you now do the Zillness staining.
yes,
We take 3 samples. You also do it for culture and NAAT.
exactly.
NAAT.
So three
Okay.
specimens for your gram stain, for your acid fast stain, 3 cultures, 3 specimens, but you take them 8 hours apart. 3
Okay.
specimens for your acid fast, 8 hours. And if the first one no catch am, the second one go catch am. If the second one no catch am,
Okay.
the third one go catch am. Then once you
Okay.
obtain a positive result there, you now proceed to do your NAT and also your culture. You understand?
Okay.
That's the way it works.
Okay.
So
So the Zillness staining and gram negative staining will give you the same picture.
the gram negative
The
staining,
yeah.
but you will know because the background is going to be showing your blue background and you see
organism.
yeah, like I'm sure you are familiar with this kind of picture. You will know. There's no way you will not know. You will know.
Okay.
So, what's the counter stain that they usually use in gram stain? Usually red. Do you get? It's red, saffronin. But this one is going to be blue or green. Do you get? Dr. Antonio?
Yes.
Yeah. So that's the way it works. Okay. So, the most common finding is what? Cavitary infiltrate on the upper lobe. We know this. So once you are seeing cavitary infiltrate on the upper lobe, you know that this is like a secondary reactivation. A secondary reactivation, and that can be associated with the calcification of the lymph node, which is your Cons complex. So this is a cavitary lesion here. So you know that this person is having secondary TB. If it's primary, you see it at the lower lobe or the middle lobe. You can see this nodule millet-like dissemination. So this means that TB has spread to the blood. So this is what we call the miliary TB. You can see this millet-like nodules. People with TB or people with HIV or people with the primary TB can have their own in the lower lobe, because HIV might not have adequate immune response to take the lesion up. So the lesions will still be confined to where the primary site is, which is at the lower part. You can see the nodules disseminated in a miliary TB, which indicates hematological lymphatic dissemination. Now, this is where you will need to calm down again. Now, if you test somebody and you confirm latent, you test somebody and you confirm active, you have to report to the local and state health department. If you see that in the option, pick it, report it. Because somebody with latent can also still, develop the active, and they can develop the infection. So, report to the local state authority. They are going to take it up from there. If the person is having active, you have to isolate them, right? Isolate them in a negative pressure room. So, a negative pressure room means that in that room, air can only come in, air cannot come out. So there's no way the individual, even if the individual sneeze, the droplet will not be able to leave that room. It will be confined to that room. Negative pressure. Negative pressure only sucks. They cannot release. That's the way to look at it. Put them in a negative pressure room and ensure that any health worker that is entering their room should be wearing N95 mask, because the fact that you are in negative pressure room no mean say you know if you get them, because all the droplet will be confined to that room, and if you are inhaling naturally in that room, you will develop this stuff too. So protect yourself by using your N95 masks. You must treat the latent disease. It's a composite. It's commonly tested in the USMLEs. You treat it, and what do you give? So the way I picture it in my mind is, I can give rifampicin, I can give isoniazid, or I can combine both of them. If I'm combining both of them, the duration I'm going to give it is going to be shorter. If I give rifampicin, which is like the major, the duration is going to be in the middle. If I give isoniazid, the duration is going to be long. So if I give isoniazid only 6 months, rifampicin only 4 months, combine both of them 3 months. Is that easy?
Sorry, you said isoniazid for 6 months
Isoniazid
alone?
only 6 months, rifampicin
Okay, we can't
4 months,
alone.
combining them
4 months.
3 months.
Okay.
Active disease, you have to give directly observed treatment. So I give the 4 of them, rifampicin, tavudor, pyrazinamide, and isoniazid. I give it the 4 of them for lesser time, 2 months. Don't forget the algorithm. That's where you remember. Once you are giving more drugs, it's going to be for a shorter time. So the 4 of them for 2 months, and only isoniazid and rifampicin for 4 months. Total 6 months. What are the side effects that you should not forget? Ethambutol can cause optic neuritis. Don't forget that. Isoniazid has a lot of problems: hepatitis, vitamin B6 deficiency, lead to peripheral neuropathy, sideroblastic anemia, lupus-like manifestation, CYP inhibitor, a lot. Pyrazinamide, you cannot forget that it causes hepatitis and hyperuricemia. It is dangerous. It is dangerous to forget that. Pyrazinamide can cause hyperuricemia and gout, as well as hepatitis. Rifampicin is an enzyme inducer. You have to be careful. It can also change the color of the body fluid to red or orange. Okay. So for the let me see, do I have a question here? Tuberculosis. Oh. So, an 80-year-old woman is brought to the hospital due to 3 weeks of persistent fever, chest pain, cough, productive cough. The patient was seen in the office 2 weeks ago for these symptoms and was given a week-long course of level due to suspected right lower lobe pneumonia. Okay. She has a history of type 2 DM dementia and resides in a nursing home. Temperature is elevated, blood pressure okay, oxygen saturation okay. Examination showed decreased breath sound and right lower lobe. Chest imagery reveals increased right lower lobe infiltrate, right pleural effusion, right side hilar adenopathy compressing the middle lobe bronchus. Which of the following is the most likely cause of patient condition? What are we picking? Hilar adenopathy, lower lobe infiltrate, effusion. Yeah? Which one?
Tuberculosis.
Tuberculosis. What type of tuberculosis? Primary, secondary, tertiary, quaternary, or latent?
I think primary.
Primary tuberculosis. That's fine. And what risk factor can we pick from here?
He has type 2 diabetes and she also stays in a nursing home.
Okay, that's fine. That's fine. So, a 7-year-old boy is brought to the office as a new patient. He has not seen a physician since immigrating from South Africa with his family 1 year ago. His parents reported that he has been healthy except for occasional episode of nasal discharge and sneezing while playing outside. Medical history is remarkable for infantile atopic dermatitis treated with emollients. He has received all the appropriate childhood vaccination, including oral polio and BCG vaccine in South Africa. His mother says that the family has no known contact with anybody infected with TB. Vitals are okay, lungs is clear. Reminder of the physical examination shows no abnormality. Which of the following is the most appropriate next step in the management? Look at this question carefully. What are you going for?
IGRA.
IGRA. Why?
As the child received the BCG vaccine, so if you do tuberculosis test, you may get positive result.
We keep it simple. Okay. So for the non-tuberculous mycobacterium, we don't need to waste our time. The only thing we just need to know is that the commonly tested one here is the Mycobacterium avium complex. And the most important predisposing factor to the origin of this avium guy is just immunodeficiency, either from HIV. Maybe the CD4 count is going to be less than 50. Once the CD4 count is less than 50, the person is going to be playing with avium. What are you looking out for? A cavitary lung disease. Most of the time, you are going to see them having a cavitary lung disease. Maybe the person has COPD or cystic fibrosis that's already causing some cavitation. They can have superimposed Mycobacterium avium infection. And, that might be the primary presentation. But in people with TB, in people with HIV, with CD4 count less than 50, they are going to have a disseminated one beyond the lungs. So, the most common places it goes to is, number one, the GI. They have diarrhea, which is just going to be watery, not bloody, please. Watery diarrhea, it goes to the liver. They have hepatosplenomegaly. It goes to the lymph node. They can have lymphadenopathy. It goes to the bone marrow. It can even go to the adrenal. That is Mycobacterium avium for you. So, you see a patient and you are thinking of tuberculosis and the person is having bloody diarrhea, please don't go and pick Mycobacterium tuberculosis. Just pick your Mycobacterium avium. You will be correct. So those are the non-tuberculous mycobacteria. You also have the Mycobacterium meridionum, abscessus, ulcerans. All these ones just cause chronic non-healing wounds. So you see somebody having non-healing wound or ulcer, think about mycobacterium ulcerans. That's really ulcer. It's commonly tested. All these chronic abscesses, yeah, maybe, but don't forget mycobacterium ulcerans. They're usually ubiquitous. They don't cause any problem unless there is a, like a predisposing factor, either immunosufficiency or there's an underlying chronic lung disease like cystic fibrosis and COPD. In that situation, they are going to be having cavitary lung disease. If there's HIV, there's going to be disseminated form. The person will be presenting with tuberculous-like presentation in the lungs, hepatosplenomegaly, adrenal problems. They can go to the GI and cause poultry diarrhea. So there's the primary form, which can occur without any problem. No HIV, no COPD, no cystic fibrosis. We call that the Lady Windermere syndrome. So don't worry yourself about this. This is just talking about individual having like some of those infiltrates affecting the right middle lobe and the lingula of the lungs, because that area you need to cough to bring out sputum from that area. So, but this Lady Windermere, is a old lady, and old people don't typically cough. So they tend to have more of the infection settling within that area, and they have some X-ray findings like infiltration of the lingula, right middle lobe, leading to scarring voluma at the middle lobe and the lingula. That's not very high yield. You can have secondary form in which there is underlying COPD or cystic fibrosis, and they develop the cavitary pulmonary lesion. And when there's HIV/AIDS, CD4 count less than 50, they have the disseminated form. I think that should be very clear to us. Do we understand it? I've just summarized whatever is in this.
Yeah, so the secondary form is for those that are immunocompromised, right?
So
HIV and COPD.
Yeah, so if the second form can encompass the two, you are correct. But what you use to differentiate them is that if there's 8, it's going to be disseminated. But if it's only COPD or cystic fibrosis, you're going to confine to the pulmonary area only. Do you understand?
Okay.
So,
okay.
So hepatosplenomegaly, lymphadenopathy, adrenal insufficiency, they can have bone marrow infiltration, severe anemia, diarrhea. Don't forget GIT. Don't forget, and of course, you should obtain your culture, which is going to be positive in 2-3 weeks. And because of the fact that these things affect the liver, the bone marrow, so they can have anemia. It affects the liver. It's going to be hypoalbuminemia. You notice that the alkaline